Good to go live, ma'am.
A very good evening to all present here. I welcome everyone to the much awaited continuation of the Women in India Nephrology web series. That is today's topic being nutrition and dialysis. So, yeah, are my slides visible?
Yes, Megha.
Okay, so as Hippocrates, the father of ancient medicine, once said, "Let thy food be thy medicine." Nutrition is a key component, albeit a very neglected one, in treating the chronic kidney disease patients, especially those on renal replacement therapy in the form of dialysis, whether it be hemodialysis or peritoneal dialysis. So I hope that by the end of this lecture, each one of us is more confident in handling the nutritional aspects of these patients. And now, without much further ado, let me introduce the chairpersons for our first session today. Our first chairperson being Professor Dr. M. Srilata ma'am. She is the professor and head of Department of Nephrology of Government Medical College, Kozhikode. Welcome, ma'am. Our second chairperson is Professor Dr. S. Renuka ma'am. She's currently working in the Department of Nephrology at St. John's Academy of National Health Sciences, Bangalore. Welcome, ma'am. Our third chairperson for this session is Professor Dr. Saxena Alexander ma'am from the Department of Nephrology at CMC Vellore. And the fourth chairperson for this session is Professor Dr. Mayuri Trivedi ma'am. She is the head of Department of Nephrology at Lokmanya Tilak Hospital, Mumbai. I welcome all the chairpersons, and now I request Professor Dr. M. Srilata ma'am to kindly introduce our speaker and the topic for the first session. Yeah, sorry.
I think Dr. Srilata madam is yet to join. We have requested Dr. Renuka madam to introduce Dr.
Okay,
Premvada.
so can
Madam,
I request
Dr. Renuka madam, can you please introduce Dr. Premvada, the first speaker of this session? Dr. Renuka madam. Dr. Renuka madam.
Ma'am, you're muted, ma'am. Can you hear now?
Yes, ma'am.
Yes, ma'am.
Yeah, good evening, everybody. Nice to see you today, this evening. Dr. Premvada does not require any introduction to this meeting, but anyway, to formally introduce her, she is a mentoring nephrologist platform from ERA EDTA. She's an editorial board member of BMC Nephrology. She's an editorial board member of Indian Journal of Kidney Disease. She's a member, Board of Studies, Pondicherry University, 16 publication in Index Journal, 5 book chapter, and peer reviewer of many leading nephrology journals. She is presently the professor of nephrology at JIPMER, Puducherry. Over to you, Premvada, for your talk today.
Yeah. Thank you, madam. Thank you, madam, for the kind words of introduction. Siddharth, can you enable me to share my screen?
Yeah, ma'am, I will stop sharing.
Yeah.
Yeah.
Yeah, as Megha told, nutrition is a sort of a neglected topic when it comes to the care of kidney failure patients. Probably the more dramatic clinical and laboratory parameters get all the attention, and nutrition is something settled, but yet decisive in deciding the prognosis of those who are on dialysis. So unlike the protein energy malnutrition associated with starving, the nutritional defects in kidney disease is not just because of low nutrient intake, and at the other side, there is active wasting happening. So that is why, rather than simply calling it as protein energy malnutrition, the current term is to call it as protein energy wasting. There is nutrient deficit on one side, and on the other side, there is higher catabolism, which is produced as a result of uremia, toxin, dialysis, and multiple other factors. So in the worst case scenario, the ideal marker for protein energy wasting, it should be able to identify and risk stratify patients with protein energy wasting. And more importantly, it should distinguish the effects of protein energy wasting from that of disease. And that is where our old markers like albumin and pre-albumin miserably fails. And it should be able to diagnose nutritional interventions, and it should be able to monitor the response of nutritional interventions. And also, we should be able to see whether any of the nutritional interventions are of potential benefit. Problem is, unfortunately, we don't really have such a marker. So in general, there are three aspects of the nutritional assessment. To begin with, we have to make an assessment of the diet the patient is taking. Dr. Meenakshi Bajaj will be speaking more on how to make the dietary assessment. It could be in the form of dietary recall or by using some semi-quantitative scales to assess the status. Then it involves a physical examination and laboratory parameters. So the first meaningful guideline on assessing the nutritional status was put forward in 2008 by International Society of Renal Nutrition and Metabolism. So as I told, there is no universal marker which is going to identify protein energy wasting in dialysis patients. So basically ISRNM has suggested a panel of 4 tests, combining serum chemistry, assessing the body mass, muscle mass, and dietary intake. And they have laid down very clear guidelines, and from each category, at least 1 should be positive and 3 out of the 4 categories has to be met. So the most common thing, the first thing we all do it routinely is serum albumin, pre-albumin, and serum cholesterol. Pre-albumin, even though many centers doesn't do, but we are all familiar with these things. Now let us see what are the problems by taking these markers alone as a marker of protein energy wasting. The problem is albumin in all studies, in many studies, it correlates with the mortality of dialysis patients. But the problem with albumin is it's a marker of inflammation rather than nutrition, and the half-life is going to be 20 days. So when a patient is hospitalized, albumin falls, but we don't know whether it is because of the inflammation or whether it is because of the nutritional deficit. And situations like liver disease and other acute illness may lower albumin. And if you simply rely on albumin, it might give us a spurious feeling that probably the patient is going for more severe protein energy wasting. And somebody who is having a gastric protein wasting enteropathy, again, albumin tends to be low. So pre-albumin is having a much more shorter half-life compared to albumin, so makes it a better marker for monitoring the response to nutrition. But again, it is not without flaws. It's dependent on the GFR. So we can use pre-albumin cutoff of 30 only in dialysis patients. In patients who are not on dialysis, the pre-albumin levels might vary depending on the GFR. The problem with pre-albumin is, again, it exhibits a sort of negative acute phase response. It is reduced by inflammation as well as the liver diseases, and it can be increased by steroid therapy and alcohol intoxication. Cholesterol less than 100 generally means severe protein energy wasting, but the problem is cholesterol lacks sensitivity and specificity, so there is not much of strong data on cholesterol as a nutritional marker. Now, the next thing which most of us commonly depend is the body weight, and we put it into body mass index. And this is the Indian criteria for categorizing obesity in Indians. So less than 18.5 is considered as underweight and 24.9 is considered as obese. These cutoffs are slightly different for compared to the Caucasian populations. But let us see how actually body mass index correlates with mortality in dialysis patients. So now we can see that the mortality is lowest when the body mass index is above 25 and between 40. This is very well, even according to international standards, this is the area where we call overweight and obese. So does it mean that obese patients tend to do better on dialysis? And this is, again, shows some data of dialysis patients, like the survival of dialysis patients. The dotted lines shows the patients who are alive, and the solid line shows the patients who are dead. And now we can see that people who die because during dialysis, right from the beginning, they tend to have a low body mass index. And as they go down, as they survive for longer duration, the BMI keeps on reducing. So this is otherwise called the survival paradox or the obesity paradox. In general population, as you can see from the red line, as the body mass index rises above 25, there is a gradual increase in mortality, whereas the reverse is going to be true in CKD patients. Now, what are we going to tell our patients on dialysis? Just increase your body weight or don't lose weight? So the problem with body mass index is these two people, we know they don't look similar. One person has around 35% of muscle and the other person on the other side have 15% of muscle, but they can still have the same weight and same height. If they have the same weight and same height, the BMI is going to be same in these patients, but obviously they don't look similar. So BMI fails to differentiate fat from muscle. What happens in CKD, the overall weight might be maintained, but the body composition changes very early in CKD. Their patients might start losing mass, and the fat and the muscle might get replaced with fat without obvious changes in the weight. And again, as people age, the muscle gets replaced by fat. Again, actually, the weight need not change always. And this does not differentiate the sex variations in body weight, body shape. At any point of time, females tend to have more fat compared to males with a corresponding height and weight. So BMI also does not account for this, and BMI does not reflect the muscle mass. So basically the problem with BMI and adiposity is we can see that, okay, there is sort of clustering and the correlation seems to be decent. But the problem is, let us look at this figure. If we use BMI cutoff of 30 as a cutoff for obesity, this is from a paper outside India, so that is why 30 is taken. We can see only a very small fraction of the people are diagnosed to have obesity. Now, again, when the same exercise is done with the body fat percentages, more than 2/3 or so is diagnosed with obesity. The relationship between BMI and adiposity is not linear, and adiposity always tends to have an adverse effect on the outcomes. So this is again another study which is showing the relationship between BMI and the all-cause mortality. So here on the y-axis, the hazard ratio is given. That is why it shows a little bit inverted compared to the previous figures. And now we can see that as the BMI increases beyond 30, there is a steady decline in the mortality. This again gives the impression that more fat or obesity is going to be beneficial. Now, the same data is repeated with body fat percentage on the x-axis instead of BMI. Now we can see that once the body fat exceeds 20, there is a steady increase in the mortality. Now, coming to the muscle mass, the relationship between BMI and muscle mass is even bad. We really don't have much data in Indian population. This is actually our own study, which was done in pre-dialysis patients. Now, if we calculate by BMI, you can see a good majority, at least 60% of the patients have normal BMI and a minority are overweight and obese. Now, we assess the muscle mass by DEXA, and we used an Asian work group criteria for the diagnosis of sarcopenia. Now you can see that those who are underweight is 100% sarcopenic, and those who are having normal body weight, a good majority, almost 70% is sarcopenic. And if we just take BMI of 23, that is the cutoff for obesity in Indians, you can see that the proportion of sarcopenics with a BMI more than 23 is somewhat similar. So what we can say is, suppose if the BMI is less than 18, that means that the patient has protein energy wasting. On the other hand, if the BMI is in the normal range or if BMI is in the higher range, we cannot definitely conclude that the patient does not have protein energy wasting. So by understanding this dissociation between the muscle mass and the fat mass in CKD, in the last 10 years, the muscle mass in CKD has actually gained quite a lot of attention. So normally in state of health, protein synthesis is happening on one side and protein degradation is happening on the other side, and these two are perfectly balanced. But what happens in kidney diseases and other chronic diseases is the protein degradation takes the upper hand and the protein synthesis is marginally low. So as the disease keeps on progressing, the patient will actually keep on losing muscle. So these are a number of studies that has assessed the sarcopenia prevalence in dialysis, and we can know that sarcopenia is universally present in all dialysis patients. Only what is different is the number of patients who are sarcopenic. Now, again, till recently, we were not having never know what was the definition of sarcopenia. So some people initially used to look at the muscle mass. When muscle mass was low, it was called sarcopenia. And some people just looked at the muscle strength and called it sarcopenia. But now you want to call someone as having sarcopenia, you should have a low muscle mass as well as a low muscle strength. So basically, if we look at this chart, this is again the survival graph which shows the survival of patients based on their muscle mass and muscle strength. you can see that the survival is best for patients who have normal muscle mass and strength, and the survival becomes somewhat lower when they have a low muscle mass alone, but when they have a low muscle strength, it is even bad. And when they have both low muscle mass and low muscle strength, they are having the worst survival. So in dialysis patient, we need to look at the muscle mass. Now, how are we going to look at the muscle mass? So in dialysis patients and in CKD patients, based on the body composition, there are 4 phenotypes: the normal, the obese individuals, and sarcopenics only, and another group of patients who have sarcopenia and sarcopenic obesity. And the survival actually is decided by these phenotypes. Now we can see that in CKD patients, those who are sarcopenic and those who are obese, they tend to have the best survival, and the worst survival is for sarcopenics and somewhat intermediate survival for those with sarcopenic obesity. So identifying sarcopenia is of extreme importance. And if they are sarcopenic, unfortunately, we don't have a way to prevent sarcopenia. That should actually start very early from CKD stage 3 or right from the diagnosis of CKD stage 3. Unfortunately, we never pay attention to the muscle, and most of the patients, as they pass on to dialysis, they end up being sarcopenics. So now, how are we going to identify this sarcopenia? So it's not really difficult. There are screening tools available, which we can actually use in our OPD practice. And this screening tool, well, this is commonly used screening tool, is called a SARCF questionnaire. And it hardly takes 2 or 3 minutes to administer a SARCF questionnaire to a patient in an outpatient practice. Now you can see it is based on 5 parameters. You are assessing the strength. There are 5 questions which the patient has to answer. Now, if you see, these questions, they are not really focused on CKD patients. This is a generic tool. This is something which has been used in old age, and it has been found to be useful in other situations also. We don't have a disease-specific tool for assessing sarcopenia and kidney disease, so we are using this generic tool which is used for other population. Now, as you can see, this is focusing on the old age. So basically, this has a very high specificity, but the sensitivity might not be that good in CKD, but we don't have any other better tool. This is the one which has been maximally used. So the working groups on sarcopenia has suggested using this tool. So any score more than 4 means probable sarcopenia. There is another tool called the Ishii screening test. Basically, for that, we need the age, grip strength, and calf circumference, and that is converted to a score with the help of an equation. But there is not much of a really good data whether Ishii screening test is useful in patients with CKD, and it is mostly from patients' old age and other diseases. So this is what the European Working Group for Sarcopenia in old age recommends. So this is the only recommendation which is available. We don't really have any recommendation from Asian working groups and all. So first, you have to find cases using a SARCF questionnaire. So now if the SARCF questionnaire shows a score of more than 4, that means the patient has probable sarcopenia. So you have to assess the muscle strength. The muscle strength, you have to do a test for upper limb, and you have to do a test for lower limb. So in upper limb, there is something called a Jamar dynamometer. So you ask the patient to hold, and it assesses how good the patient's grip is. And the chair stand test is simple. The patient is seated on a chair, and you ask the patient to get up from the chair 5 times and sit down and again get up, and the patient has to repeat it 5 times. And if the patient takes more than 15 seconds, that is considered as defective lower limb strength, and both these tests are considered to be positive. And if the hand grip strength is low, there are cutoffs, different cutoffs for males and female, and the chair stand test takes more than 15 seconds. This is considered as probable sarcopenia. For all practical reasons in clinical practice, if the SARCF questionnaire score is more than 4 and the hand grip is weak and the chair stand test takes longer time, we are going to consider it as sarcopenia, and we have to start on remedial measures. But maybe for research purposes and all, if you want to really look at the muscle, then you have to confirm the muscle quantity and quality with a tool, radiological tool like DEXA, bioimpedance assay, CT, or MRI. And there are various ways of assessing the muscle mass and various cutoffs depending on the method you used. One of the common cutoffs which is suggested is for Asian population is you look at the amount of muscle in the appendages. And if the appendicular skeletal mass is less than 20 kg or 15 kg, that is considered as sarcopenia. You can even normalize it to the height. So that will give something called an appendicular skeletal mass index. It is similar to our body mass index. Instead of the weight, we are putting the appendicular skeletal mass in the numerator. And there are cutoffs for different populations. It is 7 and 5.5 in Asian population, whereas in Caucasians, it's slightly on the higher side. Now, once you confirm the sarcopenia, there are a battery of tests. We again ask the patient to perform this test. And if any of these tests are positive, that is considered as severe sarcopenia. This includes asking the patient to walk and assessing the gait speed, then find out how much is the time taken by the patient to take a 400-meter test. And there are other tests like the patient is seated on a chair. We ask the patient to stand up, walk for 3 meters, come back and sit down, see the time. And then there's a battery. SPPV is a battery of tests which actually incorporates a chair stand test, a walk, and another test of balance. So we need not do all these tests. Anything which is feasible in the outpatient department or IPD is possible. And actually it is not very difficult to administer this test. And it hardly takes 10 or 15 minutes. And a trained paramedic can actually do this test with a good amount of reproducibility. Now, to find out how much muscle the patient have. So rather than the fat, which decides the prognosis in dialysis patient is the amount of muscle the patient has. So basically, we have to look for body composition. There are different models of body composition. The basic model, the 2-compartment model, we will get the output from whatever test is fat mass and the lean mass or fat-free mass. Now, we know that the lean mass or the fat-free mass is composed of bone. If we use a test like DEXA, we'll be able to assess the muscle mass, bone, as well as the fat mass. But again, the lean mass is composed of tissue and water. We have advanced model that will actually give the muscle mass subtracted from the total body water. So actually, there are multi-compartment models also. Probably in a decade or so, we will actually have multi-compartment models of body composition analysis. There are so many tools for body composition analysis. I'm just talking about the common ones that can be used in our day-to-day practice. So the first and foremost one, now considered as the gold standard, is DEXA. There are many other research methods like air displacement plethysmography, underwater weighing and all, but these methods are quite cumbersome and they cannot be used in the day-to-day practice. So DEXA has been validated against these methods and DEXA has been found to have very good reproducibility. So basically DEXA is based on the attenuation of 2 X-ray beams. Different tissues will attenuate the beams to different extent. So if we have the normative data in population, in a healthy population, we can derive an equation by measuring the attenuation of these 2 beams. We can actually calculate how much fat and how much mineral and how much lean body mass the patient has. So DEXA gives 3 compartments. DEXA is dividing the body into 3 compartments and gives information on the fat mass, the lean body mass, and the bone mass. So DEXA gives quite a lot of outputs. What is needed for us nephrologists is we want to know how much is the fat mass. And again, we can normalize it to the height like BMI, that is called a fat tissue index. And the lean body mass, either we can look at it in the kilograms or we can look at a lean tissue index. Similarly, that will give the appendicular skeletal mass in kilogram as well as in the index. In addition, DEXA also gives visceral adipose tissue also. So till recently, like GE and Hologic were the 2 manufacturers of DEXA, and they use their own data. Now, recently, still a couple of maybe 2-3 years back, this NHINS has published their normative data on body composition, and now whatever the machine gives output, that is based on the normative data. Again, DEXA, one problem is DEXA can be affected by hydration stage, and there will be a margin of error, but still it is considered as acceptable. But the problem is the DEXA values might not be reliable if we do it in a edematous patient. If we want to do DEXA, do it when the patient is closer to euvolemia, maybe on the same day of dialysis after allowing the fluids to equilibrate. The problem is DEXA platform can hold oversized individuals, but the problem is if the patient is too big or too tall, part of the leg or head might be outside the frame and part of the body might be outside the frame. So there are imaging techniques like we can actually do 2 images with one side in and the other side out and reverse it the later time. But the problem is the accuracy gets compromised when we do this sort of maneuvers. And generally, fat is underestimated with DEXA when compared to gold standard techniques. And again, the problem is, I told you, the available DEXA systems use data from NHNES. And at any given body weight, an Indian patient or a South Asian patient will have higher fat compared to the Caucasians. So it again underestimates the fat in non-Caucasian populations. So coming to, and despite all this shortcomings, DEXA is going to be a useful tool. The coefficient of variation of DEXA between different machines is less than 1, which means that the reproducibility is going to be great. And for all practical purposes, DEXA remains a gold standard and newer tests are always compared against DEXA now. Now going to bioimpedance, we are all familiar with bioimpedance. So basically for bioimpedance, the human body is considered as a cylinder. The basic model, human body is considered as a single cylinder, which is able to conduct a current. You apply current on one side of the body and you measure it at another side. And there are different types of bioimpedance assay. Single frequency means that it uses only one frequency. Anything which uses more than one frequency is called multiple frequency. And bioimpedance spectroscopy uses a broad band of frequencies. In short, the more frequencies you use, the more information you get, and the data is more going to be accurate. And to begin with, the entire human body was considered as a single segment. Now we have segmental bioimpedance machines, which actually consider body as a combination of 5 cylinders, 4 being the limb and the trunk being the remaining 1. And again, even though trunk contributes quite a major portion, most of the bioimpedance is generated from the limbs. Now, a little bit on the principle of bioimpedance. So in short, bioimpedance is a sum of resistance and reactance. Reactance is otherwise called capacitance. So when a low frequency current is passed, what happens is this low frequency currents cannot actually penetrate through the cell walls. So they will go through the interstitial fluid and they can be measured on one other side. Now, when we give a higher frequency current, this higher frequency current can pass through, but something else. It is not just actually resistance to the flow of current happens. There's something called reactance happens. Reactance or otherwise capacitance is the ability of certain substances to store current. And once actually they reach their saturation limit, they will actually start discharging the current. So the bioimpedance, as we measured by bioimpedance equipment, is a combination of resistance and reactance. Now we can see that when there is more fluids, that it becomes like a sort of a conductor, and the resistance is inversely proportional to body water. More body water, less resistance. And on the other hand, the reactance is directly proportional to the amount of the cells present in the body. You have more muscle, the reactance is going to be high. So, and in other words, the bioimpedance will be high. So when you have an overhydrated patient, the bioimpedance is going to be low because your body has more water compared to the cells. And on the other side, a euvolemic muscular patient, the bioimpedance is going to be high because there is relatively less water compared to a dialysis patient and more muscle mass. And again, coming to fat versus muscle, the bioimpedance is going to be higher for muscles. Now, we can actually use this information on resistance and reactance to get something called a phase angle. So normally an alternating current, we are passing a very small alternating current. The current has 2 exactly superimposed wave, one voltage wave and a current wave. So when it passes through a cell, which is having some amount of reactance, there will be a dissociation of these 2 waves. These 2 waves does not appear in the measuring electrode at the same time, and they tend to be divergent, or it is called as out of phase. So the difference, the time difference between emerging of this voltage wave and the current wave can actually be measured, and it can be converted into a mathematical figure called a phase angle. So an intact cell will give you a bigger phase angle, whereas on the other side, a damaged cell or lower number of cells, the phase angle tends to be low. So this is actually the resistance and reactance are plotted on X and Y axis, and whatever angle we are getting is called the face angle. And the lesser the face angle means that less tissue in your body and the survival is going to be worse. The problem with bioimpedance assay is it is not as simple as it sounds. There are a lot of mathematical equations going on, and bioimpedance assay is also validated in healthy individuals, assuming that 73% of the lean body mass is water. Now, in a dialysis patient who is overhydrated, the percentage of body water need not be 73. It could be 80 or 85 or even more. So now when we actually use an equation which is validated in healthy individuals, this might lead to gross underestimation of the lean body mass, and it might overestimate the fat mass. So basically this population specific equation, and another thing is this is all based on specific populations. So we don't really know whether we can actually extrapolate the information into other ethnic groups. So as an answer to this, this bioimpedance vector analysis is proposed recently. So bioimpedance vector analysis, I know that this diagram is a little bit complicated. So basically what we do is XC is the reactance and R is the resistance. So what we do is we can measure the resistance and reactance, and the resistance corrected to height is plotted on the x-axis, and the reactance corrected to height is plotted on the y-axis. Now, bioimpedance is a property of resistance and reactance. Now, basically, if the patient is edematous, what will happen is the bioimpedance is you're going to get this graph somewhere here. And on the other side, when the patient has actually more mass, muscle mass, the reactance is going to be high. There are two components of this bioimpedance vector analysis. One is the phase angle. So basically phase angle is nothing but the ratio of the height adjusted resistance and reactance. So now if we can see somebody is having a higher muscle mass, what will happen to the phase angle? The phase angle is going to go up. And there is another component of the vector, one that is the length of the vector. The length of the vector in fact is derived from the bioimpedance. So more muscle mass means more reactance, more resistance, the vector is going to be longer. So now what will happen when the patient gets dehydrated? You're going to the same patient, if the patient is dehydrated, you're going to get the same phase angle, but the vector is going to be longer. And on the other side, if we are doing the vector analysis in a patient, in an overhydrated patient, we are going to get the vector somewhere here. So this is another thing, another data from a cardiac failure patient. First, the patient comes with anasarca. So patient is volume overloaded. So the bioimpedance vector length is going to be less, and there is more fluid in the body. So the phase angle, the reactance is going to be less. So we are going to get a lower phase angle. Now, when the patient is dehydrated, when the patient is actually treated by giving diuretics and all, the relative amount of water increases, and in the same patient, if we do the vector analysis after 1 or 2 days of hospitalization, we will see that the phase angle has increased because the relative proportion of the solid tissue has gone, or the amount of water has come down, and that actually will increase the phase angle as well as it will increase the length of the vector. Now, if the patient becomes dehydrated, the phase angle further increases, and again the length of the vector keeps on increasing. So the next speaker, Dr. Arpana ma'am, will be telling about what is the actual clinical application of this vector analysis in dialysis patients. The problem with the bioimpedance assay is hydration can affect the result to a greater extent compared to DEXA. And again, actually, this is data is derived from patients and within a normal range of weight. So maybe we cannot use it for very obese patients as well as very thin patients. Skin fold thickness based measurements, that is something which is handy, but skin fold thickness based measurements has a little bit of problems in Indian population. The problem is there are many ways of doing the skin fold thickness measurements. What is commonly done is we measure the skin fold thickness with the help of a caliper at 4 places. One is biceps, triceps, suprascapular, and iliac. One of the basic assumption of this thing is we measure the thickness and we put it into an equation which is again derived from Caucasian population, where the body fat tends to be uniformly distributed, relatively uniformly distributed. It might be less on biceps and triceps, it might be higher on suprascapular and the iliac crest, but it might not be disproportionately higher compared to the Indian population. Now, the problem in Indian population is we tend to have less of triceps and biceps skin fold thickness, and we tend to have more of suprascapular and iliac thickness. Now, when we use an equation which is validated in Caucasian population, it actually gives quite a lot of different results. This is our own experience, again, not in dialysis patients. So what we have done is we have compared the DEXA and skin fold thickness based equations. The problem is skin fold thickness underestimates the fat by 5 kg, and that is going to be quite a huge margin. Even though the correlation is somewhat okay, gross underestimation will be there, and we cannot actually use it to identify the protein energy wasting. Probably what we can do is we can use it to track the changes over a period of time, because it shows an excellent correlation with DEXA over a period of time. It systematically underestimates. That underestimation remains 5 kg at beginning or after a couple of months. Now coming to CT scan. CT scan generally, it can be used to estimate the muscle quantity as well as quality. But the problem is we are using ionizing radiation. Getting whole body acquisitions are not going to be easy, might be hazardous for the patient. And again, the problem is we cannot keep on repeating it as an assessment of nutritional status. So basically what generally is done is two things. We can assess the volume of the quadriceps, or we can assess the volume of the muscle at the level of L3 vertebrae. You can see in the upper slide what area marked in red is muscle, and in the lower one, this is a person who has protein energy wasting. Advantage of CT scan compared to DEXA and bioimpedance assays, it's not affected by hydration. And again, adipose tissue is not just there in the subcutaneous plane, it is there in the muscle, it could be there in the liver, and CT is capable of estimating fat in other organs as well. The problem is ionizing radiation. And again, MRI is considered to be the best in assessing the body composition, because CT can assess the fat, but again, the subcutaneous fat is not completely fat. It is 80 to 90% fat tissue and around 10 to 15% water. So MRI can precisely subtract the water content and assess the fat fraction. So that's one advantage of MRI. And problem with CT and MRI is all this data is coming from populations who were being imaged for some other indication like advanced malignancies and all. So what we don't know is what we need is normative data from each ethnicity, and that is where it is lacking. Now we are in this phase where actually research is coming on that. We are correlating MRI with DEXA, we are correlating CT with DEXA, and the images are actually showing an excellent intraclass correlation coefficient. But the problem is we don't know what is the value beyond which we call someone as having sarcopenia or someone as having protein energy wasting. Then we can quantify the dietary protein. So in a dialysis patient, what we need is we need the post-HD blood urea nitrogen and the pre-HD blood urea nitrogen. If the patient is oliguric, whatever protein the patient is taking will be reflecting in the next pre-HD BUN. So if the patient does not have, if the patient has residual renal function, we will have to measure the nitrogen expression in the urine also. It's a little cumbersome process, but it also gives an estimate of how much is the protein nitrogen equivalent. So this is something which can be done, which can be used to monitor the response to therapy, nutritional interventions. But the problem is the patient has to be in a steady state. We cannot use when the patient is hospitalized or when the patient is in a hypercatabolic state. So the take-home message probably at the end of the session is nutrition is often overlooked in patients on dialysis, but what decides survival of a patient on dialysis is what is the nutritional status. We have limitations with conventional parameters, and just don't stop with MRI and serum markers. They are not going to give you the exact picture. You have to look at the body composition, because the fat mass and the muscle mass has predictive value on the outcome. So wherever the facility is available, you can use DEXA. It needs a slightly different software for the bone mineral density, but most of all DEXA machines are equipped with that. And if you have a bioimpedance analyzer, use it. Use it after the dialysis to assess the nutrition status. Allow for 30 minutes for all the different compartments of water to equilibrate. The other radiological methods, the data is evolving, and probably we'll have to wait a little more time, and we'll have to come up with normative values for our population. So thank you all for the patient listening.
Thank you, Priyamvada, for that very eloquent presentation of the non-biochemical parameters. I can't see any questions in the chat box from the participants, but I would probably ask you one, which is if you would want to select one biochemical and one non-biochemical parameter, which is pragmatic and best suited in a dialysis, peripheral dialysis center setup, which two will you choose?
Yeah, so if I have the facility, I would actually opt for bioimpedance assay. So advantage of bioimpedance assay is the equipment, probably we can get the basic equipment between 5 to 10 lakhs. And it is going to give information on the muscle mass, and it's going to give information of the phase angle that will help you in assessing the dry weight, and that will help you in assessing the nutrition. I would not actually, so, okay, probably I would not go for albumin, because the problem is albumin is not going, we won't be able to take decisions based on albumin. Yes, it predicts mortality, but as a community, it's like actually epidemiologic studies, albumin might be the best marker, but for an individual patient, it has limitations. But when we are working in a dialysis unit, we have to take decisions for individual patients. So that is where actually albumin miserably fails. Maybe if you want a marker, I would preferably go for pre-albumin with all the limitations in hand.
Yeah,
There are so many other things also, like creatinine kinetics and all. Why I have not mentioned this, see, these are all like research tools and probably not going to be practical in a dialysis unit.
Thank you, Priyamvada. I don't see any questions being posted. I will hand over to my next chairperson to pose any questions to the speaker.
Thanks, Asina. Dr. Priyamvada, I just have one question for you, which would probably be, taking Dr. Sasina's question forward, that do you think we can have one biochemical, knowing the fact that at the periphery level, we wouldn't have the entire armamentarium of investigations at our this. Do you think that the serum creatinine by itself could be some kind of a screening, this thing which would give us that these are the patients who would require the bioimpedance? Do you think we can vaguely correlate the creatinine levels in ESA-KD patients and then make sure that these patients undergo the bioimpedance?
Yeah, see, the problem is, okay, let me put it in a slightly different way. Let us say you have a patient on dialysis with a serum creatinine of 4 or 5. That means that the patient has protein energy wasting. But on the other side, a normal creatinine, like, okay, so not normal creatinine, a creatinine like 10 plus or so, that does not really give the information. So always be careful when you see really low creatinine in a dialysis patient. That means that don't think that you are dialyzing so effectively. That's not the case. They just don't have the muscle. The problem is, this correlates with many of the body composition markers. They correlate with the creatinine kinetics. But again, the creatinine kinetics is actually based on so much of assumptions. So that's a problem. There are actually there are other things like creatinine index and all. That's actually somewhat easier. Creatinine kinetics actually involves quite a lot of assumptions and equation. And this all goes wrong when actually we do in a slightly different population. New indices are coming. So if you ask me, can you use a single biochemical marker to identify the patients who undergo screening? Yeah. It's difficult, okay? Because we know the albumin levels, we are going to get an albumin levels closer to 3.8 or maybe lower in Indian patients. So we can't rely on most of they have their limitations. The problem is they represent inflammation as well as the wasting part. What we really want is we can't really do anything about the inflammation, but probably the wasting part can be taken care of. We can use a Sarkov questionnaire. So we are using it in our practice. So we do it in OPD. We start for CKD3 patients, and Sarkov questionnaire takes maybe 2 or 3 minutes for a trained person. A paramedic is doing it, and we do the rest of the sarcopenia screening also. The test and all 10 minutes once actually the person is trained. So at least see, it does not need any of the complex things. You need a questionnaire. Plus, you have to get a dynamometer. The dynamometer probably might cost somewhere around 50 or 75,000. And the chair stand test, probably you don't need any equipment, you need a chair only. These three things can be done. And this hardly, if we actually skip the severity part, these things can be done in 5 to 7 minutes, can be done by a trained paramedic. And if any of this thing goes wrong, these are the patients who need extra attention.
Thanks,
Yeah.
Dr.
Priyamada, there's one question I'll just relate to you. How is BCM different from BIA?
Body cell mass, BCM is basically body cell mass. You get that input from the newer, from your bioimpedance assay. So BCM is basically, body cell mass is the lean mass minus the water. Or in DEXA, what you are getting out, the output you are getting is the muscle mass. What bioimpedance does is, the bioimpedance split this muscle mass into actual solid muscle mass and water. So body cell mass is the total muscle mass minus the water content.
Sorry to interrupt. I thought Dr. Manjusha was asking about BCM. She meant body composition monitor.
Oh, okay.
I think she meant that.
So most of the handy-body composition monitors are working on the principle of bioimpedance assay. If you're asking about the Fresenius one, that's a bioimpedance spectroscope. It uses quite a lot of frequencies. So maybe in the common, because we don't really have anything portable other than bioimpedance, which can actually measure the body composition. So it's like sort of equal. But body composition monitoring is not equivalent to BIA. Many of the body composition monitors commercially available work on the principle of BIA. I hope that, I'm sorry for that actually. So I hope it's
I
clear.
think that answers the question. There's just one comment from Dr. Indumati in the chat box. It says, very nice presentation. One of our students is doing hand grip strength as a part of nutritional assessment using dynamometer and correlating with malnutrition. Any comments?
Yeah, like, see, I have intentionally skipped the nutritional scoring systems. So, yeah, it's actually, there is a lot, like, that's an area where actually a lot of research can be done. One advantage of malnutrition scoring system is it can be done by a paramedic, and it has a very high reproducibility between observers and between time. So we have to have our own data. So like, that's a good idea. And probably let us see something fruitful can come up.
Thank you, Priyamvada, for that explicit lecture. Hand over to the host.
Thank you for the chairperson and the speaker for that enlightening and informative session. To keep the program going, as a Victorian author once said, to eat is a necessity, but to eat intelligently is an art. Let us now move to the second session of the day. To chair the session, may I please invite Professor Dr. S. Gomati ma'am. She is the professor and head of department of Government Medical College, Alappuzha. Our second chairperson for this session is Professor Dr. Susan Uttap. She is the head of department of pediatric nephrology of Government Medical College, Trivandrum. Joining her will be Professor Dr. E. Induvati ma'am. She is the head of department of nephrology from Savita Medical College, Chennai. And Dr. Maitri Shankar ma'am. She is the assistant professor, Department of Nephrology, INU Bangalore. I welcome all the chairpersons and request Professor Dr. S. Gomati ma'am to kindly introduce the speaker and the topic for second talk.
Good evening, one and all. Thank you, Win, for giving me this opportunity to chair the session. In fact, it gives me immense pleasure to introduce our speaker, Dr. Arpana Iyengar, who is currently working as a professor of pediatric nephrology at St. John's National Academy of Health Sciences, Bangalore. Dr. Iyengar has a very brilliant academic track record. In fact, she does not require any introduction to this august audience. However, for the sake of familiarizing the young nephrologists and the postgraduate students, I shall briefly introduce her to this platform. Her core clinical research interests lie in CKD, neonatal AKI, renal nutrition, and bioethics. She has vast experience in the realm of nutrition in children with CKD and children on dialysis. In fact, she has done her PhD in this same subject. So she's the apt person to speak on this very important topic of great relevance in our day-to-day practice. On the global front, she has held leadership positions under the International Society of Nephrology. She is currently the editorial board member of PD International, Indian Journal of Nephrology, and Frontiers Pediatrics. Above all, Dr. Iyengar is a perfect vocalist in Carnatic music. Over to Dr. Susan for further proceedings.
Thank you, Dr. Gomti, and thank you, the WIN India organizers, for giving me this opportunity. And as all of us know, Dr. Arpana Iyengar doesn't require any introduction. And the topic of her interest, that is nutrition in children with CKD and on dialysis, is the most apt topic for her, as that is the subject of her PhD program. And I think without wasting much time, let us hear from Dr. Arpana Iyengar, and over to Dr. Arpana for her talk. Thank you.
Thank you. Thank you so much, Dr. Gomati and Dr. Susan. The Carnatic vocalist voice is not good today, so I hope I'm audible. Thank you, Vin, for giving me this opportunity, and many thanks to Dr. Priyambada for incorporating this session that deserves much attention, as equally as in adults, that is nutrition in children on dialysis. So I would begin by echoing Dr. Priyambada's statement that this is a neglected area. And I'm not just saying with experience in our own practice, but this is a global survey undertaken by the ISN and the ISRNM. And you can see here across regions, that is low income to high income countries, you can see the percentage of formal nutrition assessment being undertaken or documented. And you can see 18 to 40% in low middle income countries versus 75% in high income countries. So high income countries should have had 100% with the resources they have. And this typically gives us an idea that this is probably not a limitation only to low and low middle income countries, but it's a global problem. And once these assessments are done, who actually does these assessments? In majority of these regions, it is a nephrologist who does. But if you can see the orange bars here in low middle income and low income countries, the non-nephrology physicians are also engaged in nutrition assessment. And that's an important point that we need to keep in mind when it comes to training our healthcare workforce. So now coming to children, let me just give you some pictures just to give you an idea how children look when they are undernourished. So this is a 7-year-old girl. Many of us here would recognize that she doesn't look like a 7-year-old. She looks like a 3.5-year-old. And she's just 12 kgs, which is not what a 7-year-old should have as a body weight. This kid is 18 months old, has been on a chronic PD catheter. And you can see the catheter extruding out because the subcutaneous fat is being lost because of malnutrition. And here is a happy boy who's all round and nice and chubby and cute. He's 4-year-old, but he's short and he weighs 30 kgs. So this is exactly the spectrum of malnutrition. So gone are the days that we are talking about malnutrition that indirectly tells us only about undernutrition. Like as pediatricians, we are used to this PEM, protein energy malnutrition, wherein we know that it is all about undernutrition, underweight. So malnutrition, according to the WHO, includes the spectrum of undernutrition and overweight and obesity. This picture is very, very important for pediatric nephrology, something that no adult would even care to look at, and that's the height. So growth velocity and height of a child is critical in assessing the nutrition status in any child with CKD. So you have these two kids in the ward, both same age, 11 years old, and you see one so short compared to the other, because the shorter one had a creatinine of 11 and still walking around, no edema. So child can be so asymptomatic. The only presentation could be short stature compared to a normal creatinine child who's standing beside her, who's got a weight, the height that is appropriate for her age. So short stature growth retardation is a very, very important assessment that we have to look for in these children. So I'm going to briefly go through these main points. Many of these principles and the spectrum of the problem of assessment have been very lucidly covered by Dr. Priyam Vada, so that makes it easy for us to understand each of these applications in practice. So let me just reiterate the fact that nutritional assessment is challenging, be it in an adult or in a child, because there could be edema, which would come in the way of your precise assessments. Because of the etiology of CKD, I think this would be more important from a pediatric point of view, because we have non-glomerular diseases leading on to CKD and ESRD, wherein the child is having a good urine output, is never edematous, but is not just growing well, can have polyuria, can just have features of rickets, and these are all could be secondary to Kakut and other non-glomerular diseases. And that's the most common bunch of problems that lead to ESKD. Whereas in a glomerular disease, you would have edema, you would have oliguria, and so the assessment of nutrition differs there. There, the growth retardation is not that severe like in a non-glomerular disease. Medications could affect growth. Like if you have a child who's been treated with steroids, multiple regimes given, sometimes you have short stature because of prolonged steroids, sometimes you have obesity secondary to steroids, and then they can get into CKD. So these medications like steroids can play a major role. Comorbidities like bent bones could come in the way of your assessment of height. And as we have been saying all the time, even in the previous talk, that there is no single tool that is ideal for nutrition assessment, be it in an adult or in a child. And that's our biggest problem. And that's why the research is going on and on to explore that most ideal tool that can overtake any of these tools. And you'll say one day that, yes, this is the only measurement that I can do in my office practice to diagnose undernutrition or overnutrition. So the approach to a child would be, this is based on our guidelines from the Pediatric Renal Nutrition Task Force, is to look at the three components: dietary assessment, which is usually a 24-hour dietary recall in day-to-day practice, anthropometry measurement, and here, unlike in adults, we have long list of anthropometry measurements because pediatricians are always anything we talk about is based on body weight, is indexed to height because the child is growing. So we don't have one single parameter. We can't say BMI more than 25 is obese. No, we'll have to say BMI for centiles, BMI Z-scores for a girl, for a boy, from 0 to 18 years. So that is the complexity that we pediatric nephrologists deal with. So this is the list of anthropometry measures that are mandatory to be monitored in these children. And then you have the biochemical assessment. Again, we have only serum albumin that has a role only when you have ruled out other causes of low albumin in the child, and NPCR only in adolescents on hemodialysis. So I'm not going into the details of dietary assessment because Dr. Bajaj is going to give us those explanations more lucidly than I can. So we have dietary recall here, and what is recommended is that the frequency of these dietetic recalls and assessment is once a month in any child who is less than 1 year or older than 1 year if they are on dialysis. The frequency of other assessment measures that I had just listed out depends again on the age. So again, here it is complex because you have to look at whether the child is less than 1 year, an infant or a toddler or an older child. And then you look at the stage of CKD. And today we are talking about dialysis. So you look at CKD 5D, and you can see here, the younger the child, the more frequent the visits. As the child grows older, then from weeks, it becomes once in few months. There's this interesting term called suggested dietary intake, SDI, and that's what the PRNT guidelines suggest. So we have a range of anything we talk about, it's energy or protein for that particular age, you have a range. So you can anywhere start from, for example, you're looking at a 12-year-old kid, you start from 72 kilocalories per kg per day. And if the child is on dialysis, then you would move towards the higher end of that range, say 120 kilocalories per kg per day. And similarly with proteins. And as we all know, if the child is on PD, then we add more proteins to it, like 0.13 gram per kg more. And for hemodialysis also, we would add a little less than PD, but these are additional proteins that you would add to the recommended protein intake per day. There are two interesting studies that we have undertaken in the past few years. One is by our DM student then, Dr. Reina Rehman, who looked at dietary phosphate in these children. So it was a prospective study in CKD children, including those on dialysis, and 70 children were studied and 50% of them were on dialysis. So hyperphosphatemia was seen in 51%. And you can see that we had 50% had a dietary phosphate exceeding the daily recommended intake, and 26% with a normal serum phosphate and 94 with a hyperphosphatemia had increased dietary phosphate intake. So the more phosphate you took, then there was more chance of having a serum phosphate which was high. So we introduced a phosphate education program for the parents, and over 6 months, we saw that the serum phosphate did come down. Of course, it's a short-term study, but the serum phosphate was statistically lower than the baseline. So this is what we created, because there is no Indian food-based phosphate pyramid. And so Rena brought this, and Annie Matilda, who's a dietitian with us at that time, they brought this together. They created this pyramid, which is very useful for Indian diet. And they also are trying to emphasize the role of using a cooker and the method of leaching that would be important to take off the phosphorus from the diet. This is a more recent study that was done by another fellow trainee of ours, Dr. Shravani. So this was assessment of dietary acid load through the formula, which I'm sure all adult nephrologists are more familiar with. It's called PRAL, potential renal acid load. And this is the formula. It incorporates the protein, the phosphate, potassium, calcium, and magnesium in the diet. It's such a simple tool to undertake in your clinical practice. Anybody could just assess this in your clinical practice if you have a good dietary recall of 24-hour dietary recall, and you have these, the composition of the diet with you, you can calculate the PRAL. So in 81 patients, including those on dialysis, we had, the PRAL is going to be expressed as either positive or negative. So if it's negative, it goes in favor of more alkaline food. And if it is positive, it goes in favor of more alkali food. So we definitely want a more alkaline food, because we know acid food would add to the metabolic acidosis. And therefore we know what the consequences of having metabolic acidosis in these children are. And so we don't want that. So it's important to have a good balance and have food that is going towards an alkaline score. So you can see here the mean PRAL in non-dialysis patients and dialysis, hemodialysis and peritoneal dialysis patients are these. And we created a pyramid again in food that gives us an idea of how foods weigh in terms of PRAL value. What food alkaline, what foods are more acidic. And you can see here on the right corner that diet, nuts, and a lot of cereals and legumes had more acid content in their food. And alkaline foods would be more of fruits and vegetables and egg and milk. And surprisingly, actually not surprisingly, because we know nowadays children their tastes are so different. They would love to have a burger or a pizza or a French fries, and they think that is the normal food. And even if a home-based meal is given, the mother would say that the child would just take rice and some rasam and leave all the vegetables in the corner of the plate. I think most mothers here have faced this in our own experiences at some point. So these children actually are just on a carbohydrate-based diet, and not having any balanced diet. So it's important that they have the alkaline foods. We may not be able to reduce the acidic foods, right? But we should be increasing the alkaline foods so that gives that buffer and maintains that balance. So this is one of the important things that we saw, that most of our kids had acidic food. The PRAL values were high in about more than 90% of our children. Now I'll shift from diet to anthropometry. And just to give you a contrast of how our anthropometry is quite complex compared to adults. If you see here, this is a 10-year-old child who is height is 112. And just to let you all know, because most of you here might be from the adult nephrology background, that for a 10-year-old, 112 centimeters is quite short. So the height age, actually, that means the age at which the height 112 centimeters corresponds to the 50th centile. So that's called the height age. So the height age is actually 5.5 years. So when we look at the BMI, if you can see, we have charts. We have many of these charts. So we have country specific charts, we have WHO charts, we have CDC charts. So we can pull out any of these charts. So this is a WHO chart where it's showing us the BMI. This is the BMI if I don't take the height age, meaning I'm not considering that the child is short. I'm just taking the BMI and plotting it there. It is less than the 3rd centile. But if I take it for the height age, that means I'm considering that the child is short and then looking at the weight to height proportion, then the BMI comes above 3rd centile. So just to give you all an idea how these charts help us monitor and interpret these anthropometric measures. Besides weight, height, head circumference, BMI, we don't have mid-arm circumference as a mandatory measure in our recommendations. Mid-arm circumference is used, one, in the definition for protein energy wasting in children, and secondly, to calculate the mid-arm muscle area. And how is the mid-arm muscle area going to be important? Because mid-arm circumference is including the muscle, the subcutaneous tissue, and the bone. So if you just want to have muscle area, that muscle mass, then we'll have to indirectly calculate this from the mid-arm circumference. And this is the formula used, and we incorporate the skin fold thickness, the triceps skin fold thickness into the formula. And there you get the muscle area, mid-arm muscle area. So that's one indirect way of looking at muscle mass. This is the skin fold thickness caliper, which is Harpenden is the one we use, and this is how the skin fold thickness is assessed. There are a lot of limitations in anthropometry, biochemistry assessments. Most of them can get underestimated or overestimated because you have problems of edema, fluid overload. It's not like taking these measures in a normal child without fluid retention, without edema. And therefore, most of our tools and assessment measures have all got adapted from the adult nephrology colleagues. So when ISRNM said 2008, okay, we have PW, this is our criteria. Somewhere down the line in 2014, the chronic kidney disease in children cohort came up saying, we will have one for children too. But then they realized that children are different. We need to incorporate short stature in. So basically, it is the CKID cohort study that proposed this. So if you look at the biochemistry, there is cholesterol, which is like how you all have in adults, serum albumin, we don't have prealbumin. We have transferrin, and importantly, we have the C-reactive protein. Now, you all don't have C-reactive protein in the PW definition, but you have it in your sarcopenia definition. So they incorporated CRP because they thought that inflammation is linked to malnutrition. Reduce body mass, and BMI is the parameter. Reduce muscle cell mass, where mid-arm circumference is the parameter. And dietary intake, that is decrease appetite. Now, you all have a protein and energy assessment, but in PW criteria, it's just dietary intake is assessed by the appetite. And then, of course, the most important is poor growth, that is short stature. They further tried to categorize mild, standard, and modified PW by taking 2 categories, 3 categories, and more than 3 categories. Among these 5 categories, you take 2, 3, or more than 3 with short stature, and that would be the modified. So it's just an arbitrary classification by the CKIT study. So coming to our study on protein energy wasting, we looked at this criteria in 123 children, which included both non-CKD, CKD and dialysis. 58% had PW. And the conclusion was that appetite and anthropometry measures were more useful than biochemical criteria. And inflammation, though common, was not associated with this malnutrition or PW. So Dr. Priyamvada has highlighted the importance of body composition. It's not enough just to know the BMI, because you don't know which component of BMI is actually affected. Is it the muscle? Is it the fat? Oh, okay, if you know what's happening to muscle or fat, then what is happening to the water content? Is that coming in the way of assessment, and so on? So it's important that body composition is looked at in our patients on dialysis. And we have 2 compartments versus the fat-free mass, again divided into cell mass, bone mass, and the total body water. Total body water again divided into intracellular and extracellular water. And this fat-free mass can be, in other words, divided into extracellular mass and body cell mass. That's what you listened to when Dr. Priyamvada was talking about BCM, and I'll tell you more about it in a bit. So we have all these parameters, anthropometry measures, that are all surrogate markers. They're all indirect markers that do not probably differentiate any of these body compartments. The bioimpedance can differentiate total body water from fat-free mass and fat mass. And there's something called bioimpedance spectrometry, which is even better than bioimpedance analyzer, to differentiate intracellular from extracellular water. Then you have your DEXA, which is a reference tool for fat mass and for bone mineral content. And this is a diagram just to show you all. If you want to assess fat mass, then you can use an air displacement plethysmography, which is a BOD-POD, a DEXA, a BIA or a BIS, CT or an MRI. And I think Dr. Priyamvada has very nicely shown us how these are helpful to assess fat, body fat in these patients. I'll just give you a brief overview of how we use BIVA, bioimpedance vector analysis. So what you see here is a graph that we have created because we have undertaken bioimpedance analysis measures in 50 healthy children. You take the reactance and the resistance divided by height and plot it to get these ellipses. This is your reference ellipse. This is like your nomogram. Then you look at your patient. This is a graph where many of the children on HD were subjected to bioimpedance. We looked at the reactance and the resistance, divided it by height, and you can see all these dots here. The green dots are post-dialysis and the red dots are pre-dialysis. So whatever you see in the short arrow is when a patient is overloaded. And as you go one session after the other session and you're improving your ultrafiltration, your main aim or goal is to target dry weight. So you want to remove water and you want to see that you achieve dry weight. How do you do that? Clinically, you will look at probably the child is not edematous, the BP is better controlled, or sometimes during dialysis, you have an episode of hypotension. Now, you don't want any patient to face that. So clinical assessment of dry weight is difficult. And that's why BIVA comes into place. And we use this because after some time, after 3, 4, 5 sessions, as you remove more and more UF and you repeat the BIVA post-dialysis, you can see the point shifting from the outermost ellipse into the innermost ellipse. And that is the dry weight. So I'll give you an example. That was in HD patients. This is in peritoneal dialysis patients. This was another thesis and abstract submitted by Dr. Soumya Reddy, another DM student, who also compared this with blood pressure monitoring through ABPM. So when you have to plot these points, let's take this example. Point 1 tells us on 22nd February, the post-HD weight of a child was 26 kgs. Now we don't know whether this is dry weight or no. Then on 3rd March, what happens? The pre-HD weight becomes 27 kgs. So the child is yet to go on for dialysis, 27. So then you plot that. So you can see that the pre-weight 27, already the point is shifting towards overhydration quadrant. Then after the dialysis session, you again do BIVA and your remote fluid, right? So then you see the 3rd point is again going into the innermost ellipse. So I can, from this, assess the dry weight as somewhere between 25.8 to 26 kgs, because I want the point within that innermost ellipse. I don't want the point coming out of the outermost ellipse into the overhydration quadrant. So this is how we use. Now the red one I've shown you is very much into the overhydration quadrant. So this child will definitely come with fluid overload. This red mark is within the decreased BCM quadrant. That means there is no overhydration. The child is so undernourished and just has low BCM. What about body fat in our children? Just to give you a very short answer, the body fat was well preserved. We looked at body fat through DEXA and BIA, and in both it was only present in 12 to 18%. That means majority of our children who looked undernourished, because you see the mid-arm circumference was low in 60%, the body fat was well preserved. Then we also tried to compare, because many of the adult studies do use BIA or bioimpedance to assess fat. So we looked at how does the BIA compare with the reference tool DEXA? Is it as good as DEXA? Because DEXA has got its own problems. It's got low exposure to radiation. It's expensive. It's not bedside. So we looked at that, and unfortunately, in children, including CKD and dialysis, we found that the bioimpedance did not compare well with DEXA. So we should be very careful as pediatric nephrologists to use a bioimpedance analyzer in children on dialysis to assess fat mass. So having said that DEXA and bioimpedance have their own limitations, I would like to just give you a glimpse on this compartment. This compartment is called body cell mass. So it is a part of the fat-free mass compartment. And what's fascinating about it is that body cell mass is energy-rich, metabolically active compartment of the body. And it reflects functionally a healthy nutritional status. So in terms of research, the question came up, why don't we just assess the body cell mass? Why look at all these indirect markers and have problems with hydration? Why don't we just straight away go into this body cell mass and see what happens to this compartment in children? But remember, for whatever we do in body composition, we need a tool that is independent of hydration. And therefore, we have the whole body potassium counter monitoring. The whole body potassium counter monitoring, again, has got a very fascinating concept. All of us sitting here are emitting gamma rays. Yes, we are all emitting gamma rays even now as we speak. And how are we doing that? We're doing that because there is a radioactive potassium, K40, within our cells. So intracellularly, you have K40, and that is emitting gamma rays. We can't see them, we can't perceive them, but it's happening. So this potassium counter, which you'll see in the next slide, this is the counter that is not available in every center. There are only 5 such counters available across the world, and St. John's is fortunate to have one on campus. And so I took the opportunity to study the body cell mass in children with CKD and on dialysis. So the child goes into this counter. It's an open counter. There are sodium iodide detectors here, which detect the gamma rays that are being emitted by the naturally radioactive K40. So the concept is that K is intracellular, 98% of potassium is intracellular. If I can capture that 98% of potassium from all your cells, then I can extrapolate that to the body cell mass, because I'm actually measuring every cell inside your body. So that then I get a body cell mass. So that's the concept of this. And this is how we undertake the K counter potassium and BCM assessment. There is a formula to derive the body cell mass. And so to give you the final result, We looked at body cell mass in healthy children. We looked at body cell mass in pre-dialysis and dialysis. And you can see here that the mean body cell mass was definitely less in the pre-dialysis compared to the controls, and definitely less in dialysis compared to the controls. But what about those who have PW? It didn't matter whether you're on dialysis or not on dialysis. If you had PW, then your BCM is going to be lesser than those who did not have PW. Okay, so what? Now you got a whole body potassium counter. You say that the child has to go all over to that particular room, which is totally controlled because you cannot have any extra gamma rays coming. So it's a very tightly shielded room with steel, lead and whatnot. And a child has to lie there for 30 minutes. So can this be a clinical tool? Absolutely not. So this is just a research tool. So I was interested to look at which of our clinical parameters correlate with the body cell mass, so that I can say that if this correlates with body cell mass, I will use this parameter in clinic, and probably I will be actually indirectly measuring the body cell mass or assessing the body cell mass. And that measure was BMI for height age. So you see the correlation here, the R square was 0.68. So it had quite a good correlation, the BMI, not only at recruitment, but also on follow. So probably in these patients, the BMI reflected the BCM. Coming to the last part is the composite tools. We looked at subjective global nutrition assessment, and this is called SGNA in pediatrics, as you call it SGA in adult nephrology. And we have 10 parameters here. And as Dr. Priyamvada was mentioning, this can be done by any healthcare professional. A nutritionist, a dietitian, a nurse, a technician can do this. And we had our nutritionist, Mrs. Annie Matilda and Mrs. Sheba Collins, who took over this and did these assessments in children. And it's a scoring that you give in the end. It's a very subjective scoring. So this was done, and this is what it shows. Obviously, the SGNA score with malnutrition was more in dialysis patients. And as we looked at them, as we examined them over time, there was not much of a difference in the proportion. That means, though we are trying to treat them as a treating team, the malnutrition problem persists, and we got to do something more about it. This is a very important and easy tool, that is the nutrition focused physical examination, where you have two major components, that is the loss of subcutaneous fat and loss of muscle wasting. So just by clinical examination, you can look at hollow under eye cheeks. You can see little space between fingers with biceps and triceps pinch. You can see flat and baggy buttocks, depression between ribs. These are fat loss signs. The muscle wasting signs are protruding clavicle. Then you have the square shoulder with prominent acromion. And then you have the prominent scapula with depressions. You have thin and flat calf, and you have square knees around the patella. And you have the quadriceps that can be squeezed very easily. All these are signs of muscle wasting. And the NFPE, that is nutrition focused physical examination, is something that you can do as a point of care assessment. And we looked at, do these clinical signs, simple clinical signs, let's forget about all tools, just inspection, palpation. So can these, are these associated with PW? And we studied this systematically, and you can see here that the odds ratio for children in both CKD, pre-dialysis and dialysis, that it was significant, that they were associated with PW. Of course, the odds ratio are quite good, but you can see that the 95th confidence interval is quite wide. So that's a limitation, but then there was a significant correlation with PW. And more importantly, we looked at sensitivity and specificity of using these two clinical examination findings and signs. And we see that the sensitivity and specificity to detect PW is quite good in both groups of pre-dialysis and dialysis. And as we were all just now talking about sarcopenia, hand grip strength, there was a question on hand grip strength. I was happy to hear that, because we have just started exploring hand grip strength in children. So this is our next mission. wherein our next DM student, Dr. Mohammed Bilal, he has taken up this study along with our dietitian Sheba Collins. So we are trying to get the nephrology and dietitian groups not only sit together and manage patients, but also to undertake small scale research like this. And this is how a child uses it. So this is not the JAMAR hand dynamometer. That's usually used in the field and of course for adults. In children, we use this dynamometer, which is about 4 lakhs. It's from AD Instruments, and it's got connected to another stabilizer and then the laptop where we get these curves. So when a child actually grips the dynamometer, you can get a maximum voluntary contraction measured as a graph, or you can also get endurance. So you ask the child to hold as long as he can. So we're measuring both endurance of the muscle and also the maximum contraction. So I hope in the next few years, we will come back to you with more observations and results from these studies. But it's important to assess the muscle strength, and probably muscle mass would be the next step. We don't have ultrasound or MRI or CT scans studies on this much in children, but that also needs to be explored in the near future. So I would like to end by fondly remembering Dr. Anita Seth today. She was a person who actually gave me an idea of how nephrologists and dietitians can come together and work. I have attended her workshops in Lucknow, and I think she was a pioneer in this, to bring these two teams together to work together for better patient care. And as we speak today, we have an Indian pediatric nephrology nutrition team that has just begun work, led by Sukanya Govindan from Chennai, and supported wholeheartedly from the PRNT group from London, Dr. Ruxana Shroff and Vanessa Shaw. And we are bringing out relevant Indian-based nutrition food tables and more educational resource materials for future use. And that all this actually boils down to the concept that nutritionists and nephrologists should sit together, get trained and train many more healthcare professionals to form a bigger team. And these trainings should be assessed periodically. They should be recertified, and we have to assess the clinical implementation of these trainees when they are actually practicing. And then, most importantly, measure patient-centered outcomes. We may say so many things, but as we all know, the trend is now to find out how the patient feels about what we care for and what their perceptions and interpretations and suggestions are. Thank you very much. This is just a list of all the PRNT task force recommendations that are available free online, if anybody is interested to look at the various recommendations for children with CKD or on dialysis. Thank you very much.
Thank you, Dr. Arpana, for that wonderful presentation. And now the topic is open for discussion. And I hope that there will be a lot of interaction that is awaited.
Ma'am, thank you for having me here. Thanks to Dr. Priyamvada ma'am and Dr. Manjusha ma'am for having me here. Thanks, Dr. Arpana ma'am, for that wonderful talk. And your talks are always very amazing, and you are an inspiring teacher and a trendsetter. I just have 2 questions. How do we approach an obese child with chronic kidney disease? Should we be happy that, okay, the child is obese and he has got CKD, let's go slow on him, let's not push him to lose his weight, or should we be aggressive about his weight management? That is one thing. And second thing is, do we have to measure trace minerals like zinc, copper, and fat soluble vitamins like A, D, E, K? D, vitamin D we measure, but we don't measure vitamin A, E, and K. Of course, the prothrombin time, which is a surrogate, we don't regularly measure. We just put them on multivitamins as a blanket cover. So what is your take on that?
Thank you, Maitri. Very good questions. So the first question is on obesity. So we rarely see children with obesity compared to the West. But most of the time, this obesity is usually associated with an underlying syndrome, like Bardet-Biedl syndrome. So we have very specific syndromes that are associated with obesity. So though they have CKD, they are obese. They look quite cute, and mother's very happy that the child looks round and nice, and everybody is like touching cheeks and fondling the kid. But we know that that's not good. So adiposity, definitely, if you look at BMI, that's the measure of adiposity we have at present, and the clinical guidelines also say that BMI is the measure. So BMI is related to mortality when it's in either extremes, either very low or high. So when we say high, it is more than 85th centile to 95th centile. Again, this is in pediatrics, it's centiles. So then it's overweight. And if it's more than 95th centile, it's obese. So what we do is we document the BMI, and we are looking at the dietary recall. We obviously want to see that the calorie, protein, and fat are all within limits and not above. We don't routinely do a BIA or a fat mass assessment. There are tools to look at weight to height ratios in children for fat mass. These are all anthropometry tools, but they are associated with cardiovascular morbidities, not recommended as a tool for obesity. So we would just stop at that, look at dyslipidemia, and monitor the weight depending on the diet. So we would keep the limit on the diet and monitor the weight. Most of these kids do not lose weight if they are associated with the syndromic obesity. If they're non-syndromic, and most of our kids now, after COVID, are all sitting with their mobiles, independent of socioeconomic status. Every child, even in the poorest family, has a mobile and is glued to the mobile. And I was just telling, we were discussing in our OPD that probably we should write no mobile use in our prescriptions, because all kids are sitting, they've got a nice paunch, okay, 6-year-old, 7-year-old have got nice paunches, so they're all putting on weight, less physical activity. And that's why it's important to encourage physical activity, to assess the physical activity, and keep a check on the diet and monitor their growth over time. Multivitamins, trace elements, minerals, again, guidelines give us a lot of information, but we do not measure them. So we have a standard prescription of giving multivitamins, like you had mentioned. We measure D, but we don't measure the other multivitamins in our practice.
Thank you, ma'am. Dr. Manjusha ma'am has a question. Once you identify protein energy wasting, how and when do you start taking corrective strategies? How successful are we in this correction? Okay, so first of all, in pediatrics, the protein energy wasting diagnostic criteria itself is evolving. It's not a standard diagnostic criteria. What I showed you was just the CKID cohort proposing one, again, adapting it from the adult criteria. And you have enough to say that now PW is a recommended tool. We don't have enough evidence to say that. So it's still like a research tool. It's not well studied along with body composition, like in the adults. So I cannot say in children who had PW, was there muscle less, or was there fat more or fat less? Was the inflammation there but not associated with PW? So what am I dealing with? So we have just thrown open many more questions, I would say. Just by entering into this research, I have many more unanswered questions for the future. And therefore, it's difficult to say how we're going to manage these kids. Because unless we know what exactly is happening in these kids, it's very difficult to manage them. But let me just give you one very interesting, fascinating, latest research that has just been out there by Robert Mack, a colleague who is like an icon in pediatric nutrition in the US. So in children with cystinosis, he has found out that there is muscle wasting and fat browning. So the concept of fat browning and adipose sites and adipose tissue browning and muscle mass wasting. And these kids actually have muscle weakness. And there is this IL-6 that is implicated. So there is inflammation, and interleukin playing a role. He used anakinra as an antagonist
And that has in mice shown improvement in muscle, muscle mass. So 4 papers have just come out in the last 1 year. And I think that's fascinating because we do see this predominantly in children with cystinosis. So there's something going to come up there as a specific treatment for muscle wasting in these children.
Another question by Dr. Manjusha ma'am again. What are the indications for use of extra tools such as BIVA, BIA? Should we use them regularly? Are there any simple clinical or biochemical surrogates?
So I would say BIVA is a great tool. We are using it in our day-to-day practice. And why I say that is because if you have to assess nutrition, the first and foremost confounding factor is your edema or fluid retention. You want that out of your way, right? Only then you can say that your measurements are valid. Take, for example, mid-arm or your BMI. Everywhere there's a component of fluid. So how am I going to say, no, this is independent of fluid? I cannot be doing a potassium counter in everybody. So BIVA is a special analysis of bioimpedance, wherein if you've seen the 4 quadrants, you have nutrition and hydration going hand in hand. The 4 quadrants give you either the child is having low nutrition with overhydration or dehydration with overnutrition. The point can be anywhere. You get an idea of where the child is in terms of hydration versus nutrition. And it's not just a one-time measure. I won't say it's precise that way, but if you're using BIVA in a child longitudinally, as a child is on chronic dialysis, you keep using it to target dry weight. We have found it quite successful. Compared to peritoneal dialysis kids, the hemodialysis children have a better precise BIVA assessment in our experience. So BIVA, I would say yes. SGNA is a composite tool, so you can, but DEXA definitely is a reference measure for fat mass. But do we have anything better than that, more simpler, bedside one? Definitely not bioimpedance for fat measurement in children on dialysis. So serum albumin, we know that nephrotic syndrome kids do have low albumin. Sometimes they pass a lot of albumin through their ultrafiltration in PD. So again, they'll have hypoalbuminemia. So again, serum albumin, as Dr. Priyambada also mentioned, is not going to be a very precise tool, biochemical tool. So we don't have any biochemical tools. Anthropometry, appetite, and BIVA.
There is one last question in the chat box from Dr. Manju. She asks, will TPN during dialysis help PM children during dialysis?
So during dialysis, there are few studies that have shown that TPN did help to increase the BMI, to decrease the C-reactive protein. That means inflammation is coming down, muscle mass is increasing, and so on. They're very small sample size in these some 8 to 10 kids, not more than that. In our experience, we've had one child who was on PD, and she was so malnourished. You saw the catheter being extruded in that photograph. It was that girl. So she was an infant, and just mother's feed and some usual complementary feeds wouldn't take her anywhere. So we had to actually prepare foods for her, high energy foods. So initially we used F75, F100 because she didn't have any problems with potassium and phosphate, but she needed energy, right? So these F75, F100 are easily available. They're WHO feeding formulae used for acute severe malnutrition, but we use them. But after that, we had to use TPN, and we used Cabiven. So, that is the amino acids and lipid formulation. I have the whole formula, how we actually calculated for her. So we did use in her, and she did have increase in, we used it only for a brief 1 week. Parents couldn't afford more than that. And then, we switched on to NG feeds, which worked well. So she improved her weight, but that's the only experience we've had. So in our practice, our families don't really, they can't afford TPN for a long time, or PPN. So we advise nasogastric feeds and oral feeds as much as possible.
Thank you so much, ma'am. Lot of insights, lot of new things we learned today. Over to Dr. Susan, ma'am.
Thank you for Dr. Arpana for that wonderful session. And actually, we have learned a lot of new things you have been introducing, and you have done a lot of amazing work on nutrition assessment and nutritional status. And we hope that you will be coming out with more information and more observations and more solutions. Thank you so much.
I must tell you that Dr. Susan was one of my examiners for all this work.
Yeah. Thank you all.
I just wanted to add something. So basically, like our concept of nutrition, we had been relying on fat for quite a long time. So too less fat is bad and too much fat is also bad. But probably since the last decade, there has been some change, basically focusing on muscle rather than the fat. And this role of muscle probably was quite under-recognized in CKD, and probably the future, we are going in directions of measurements of muscle strength as well as the muscle mass. That is probably the direction to take forward.
Thanks, Premada. I think Megha, you should continue the session. Over to the
Yes,
third
ma'am.
speaker, Megha.
Yes,
We're running
ma'am.
short of time.
So thank you to the chairpersons and speakers for that educative session. As someone rightly said, life is not just in living, but living in health. With that words of wisdom, let us go to the last session of the day. For chairing this session, I invite Dr. Ranjini M., Senior Consultant, Department of Nephrology from Apollo Chennai. Welcome, ma'am. Joining her will be Dr. Ganga RG. She's also consultant nephrologist at Sri Narayan Hospital and Research Center, Shripuram, Vellore. With her will be Ms. Sunita Rao, who is the Chief Nutritionist at NU Hospital, Bangalore, and Ms. Uma Shankari D, Assistant Dietitian at the Department of Dietetics at Jipmar, Puducherry. I welcome all the chairpersons and request Dr. Ranjini M. Ma'am to kindly introduce the speaker and the topic.
Thanks for giving the opportunity. I take immense pleasure in introducing Dr. Meenakshi Bajaj, who's not a new face to us, because some time ago she had given a talk on nutrition and CKD in our state chapter meeting. She is PG DND, expert nutritionist with expertise in most of the related organs. She also holds MSc and PhD degree. She's trained in low-fat MAP and has got a lot of expertise in irritable bowel syndrome. Registered dietitian, currently working at Multispeciality Hospital, Omandurar, Chennai. She has authored many books, to name a few: Diet Metrics, Handbook of Food Exchanges 2019, Two Lives Twice as Precious, and Medical Nutritional Therapy for Hyperglycemia in Pregnancy 2023. And she's a reviewer for European Journal of Clinical Nutrition and Indian Dietetic Association. She is also member of board of various nutritional department. So over to you, ma'am.
Thank you so much for the kind introduction. Give me a moment, I'll just share my screen. Is my screen visible?
Yes.
Am I audible also, ma'am?
Yes, please go ahead.
Thank you so much to Win India for the opportunity to a nutritionist to be part of such an amazing session. And today, in the next 30 minutes, I'll try my best to run through how we could prescribe a diet for an adult on dialysis. And I thank Priyamvada ma'am especially for the opportunity. Apart from that, I'm grateful to both Priyamvada ma'am as well as Arpana ma'am for setting this context for me so that I can move with the prescription directly than talking more on assessment. So when we talk of assessment, before we talk of assessment, we need to understand, and I think we've heard more than enough, that there is protein energy wasting associated with CKD. And there is some data also to tell us that protein energy wasting lies between 35 to 60% in patients with hemodialysis as well as those who are on PD. Now, this is not an unknown story, which I'm going to again reiterate and tell you that we lose patients with CKD on HD, sometimes even before they move on to HD in CKD stage 5
And the reason being not CKD, but the reason being protein energy wasting, because it is an independent determinant of both morbidity and mortality, not only in CKD, also in HD patients. But one information which I wanted to share across here was the more the hypoalbuminemia, the more we see that it's a strong predictor of both mortality among MHD patients. Obviously, we are aware that it has a half-life of 21 days and it's a marker of inflammation more than malnutrition, but it's an important predictor of both mortality among MHD patients. And as Dr. Priyambada very beautifully elucidated the fact with reference to BMI and the obesity paradox, here I would also reiterate the fact that when a patient is obese and we have found the patient in CKD stage 5, I'm not going to push the patient to move towards weight loss. Reason one being that that's like a fixed deposit for me, because as the patient is moving towards dialysis, his intake is compromised for several factors. Apart from that, he's also losing macro and micronutrients during dialysis, which is going to worsen his health status as well as his body weight. So whenever we talk of PW, before we talk of PW and a nutrition prescription, obviously it includes screening and assessment. So the first tool which we use for screening is the Malnutrition Universal Screening Tool. Apart from the Malnutrition Universal Screening Tool, if the patient is hospitalized, they use the NRS 2002. If not, in some of the populations, though it's not a gold standard, but it's coming up in so many other conditions, people also use the GLIM criteria, which includes both screening and assessment. So when it comes to assessment, I think we've had a deep dive with reference to assessment. So I will only talk on dietary assessment. So when we talk of screening, as I mentioned to you, first, it's a known fact that most of our CKD patients, with reference to the adult patients, they are undernourished. Very few of them are not undernourished. The percentage is very, very small. So whatever said and done, if we want to identify whether the patient is at risk of malnutrition and whether he or she requires nutrition intervention, we do the first step being Malnutrition Universal Screening Tool, which includes the BMI as well as the weight loss score. And if the patient is actually ill and there has been or is likely to be no nutritional intake for more than 5 days, then all these scores put together talk to us and tell us whether the patient is at low risk, medium risk, or high risk of malnutrition, and whether the patient requires further screening or assessment. Then do we move to nutrition intervention? So when we talk of nutrition assessment, I think most of it has been dealt with. I'll go straight down into the dietary assessment. In dietary assessment, before we do the dietary assessment, obviously the anthropometric assessment, we have a long list which has been dealt with. And we have the SGA, which is the 7-point SGA, which is considered as a gold standard. Alongside, we have the malnutrition inflammation score. And the point which has to be supplemented to the already existing presentation is the chronicity index. So when we talk of the chronicity index, basically it's an index of the central obesity. It helps us in measure of abdominal obesity, but understand that if the patient is having associated ascites, then may be difficult for us to do use this particular tool. So when this tool is used, it actually helps to tell us whether the patient is at risk of any androgenic risk factor with the help of chronicity index being waist circumference divided by 0.019 square root of weight by height, wherein we find that the cutoff should not be more than 1.25 in male and 1.36 in the female subject. As I mentioned to you, the SGA is there and it's a valid clinical gold standard for assessment of patients in hemodialysis. And this is just a snapshot. And I think Dr. Arpana very beautifully took us to the nutrition-focused physical education, which is also an important part of the subjective global assessment. Basically, in subjective global assessment, we have the commonest things like the weight, the dietary intake, the consistency of the diet the patient is consuming. Are there any GI symptoms which have an influence on the nutritional intake? What is the functional capacity of the patient? As ma'am very beautifully elucidated, the chair test with reference to, Dr. Priyambada very clearly took us through that also. Apart from that, as Dr. Arpana clearly mentioned to us how we would measure the subcutaneous fat in a child. Similarly, it is done in the adult. You look for temporal wasting. You look whether the clavicle is square shaped or, the shoulder is square shaped or it is rounded, and whether the calf is well developed or no, or whether the knees, they are prominent or no. So all these things help to find out the nutritional assessment of a patient and tell us whether the patient is overall graded as subjective assessment with a score of A, B, or C, that is mild to moderate, and severely undernourished. Now, according to the Indian CKD Working Group Guidelines, December 2013, they also felt there was an important need to include inflammatory markers like CRP and interleukin-6 in order to, associated with malnutrition, atherosclerosis, and increased mortality both in CKD and in dialysis patients. So they felt that even a slightly increased CRP level predicted an increased risk of mortality in patients undergoing hemodialysis. And as I mentioned to you, there's another score known as the malnutrition inflammation score, which included 2 other lab parameters apart from what we do in subjective global assessment, is the serum albumin as well as serum total iron binding capacity, which is found to be validated as a better nutritional indicator than SGA and was reported to correlate both with morbidity, mortality, and hospitalizations in maintenance hemodialysis patients. And I think one of the attendees did have a question, and also Dr. Iyengar very beautifully showed how they've just started the hand grip strength research in their institute. This is a paper which talks about 18,765 subjects who are more than 19 years of age, wherein they found that the prevalence of low hand grip strength was much higher in those patients with CKD when compared to those who were not with CKD. And this suggested that sarcopenia should be evaluated in patients with CKD. And I think Dr. Priyambada very clearly indicated the need for measuring sarcopenia. Apart from that, whenever we have done the screening and the assessment, I think in days to go, this is how we would be writing the case sheets, that what is the code of malnutrition, whether the patient is having a sequelae of protein calorie malnutrition or sarcopenia or unspecified severe protein calorie malnutrition, the codes which will be written, which will indicate the malnutrition status of the patient. And how often should we measure? Apart from the others, the subjective global assessment should be measured every 6 months. Dietary interview, it is every 6 months according to the KDOQI guidelines. But I would say that every time the patient walks into our clinic, say at least once a month, we should do the subjective global assessment along with the dietary interview. Then we have the skin fold thickness and mid-arm muscle circumference muscle area, which obviously could be, we may get false values because of fluid overload. Then, as both the speakers have previously mentioned very, very clearly, that there is no single measure which can indicate that the patient is malnourished. We have to have a combination of these tools which will indicate the nutritional status of the patient. Now, what is my goal? As a nutritionist, my goal is first to optimize the nutrient intake, which will be possible only when I take a measure, not a measure, but a 24-hour dietary recall. Apart from a 24-hour dietary recall, I could also take a food frequency questionnaire. And in community settings, they also do the raw weigh methods in which they measure the quantity of food, the raw form which has been consumed. Then what is the cooked portion? What is the cooked portion which is consumed, and what is plate wastage? But basically on one-to-one basis, I would do a 24-hour recall and a food frequency questionnaire. Based on that and the biochemical parameters, I will get an idea as to what sort of prescription I need to prescribe. That prescription will depend on what my goals are. My goal is, suppose the patient is having hyperkalemia, in order to correct hyperkalemia and prevent hyperkalemia. Not only hyperkalemia, it could be any form of dyselectrolytemia. Apart from that, if there is fluid overload, or the patient is very tired, weak, or post-dialysis, the patient is having recurrent episodes of hypoglycemia. There could be several lists which I could mention, which would be able to help me form the goal and then the nutrition intervention. Now, suppose my patient is having cirrhosis of liver with CKD, then the course of hypoglycemia, nocturnal hypoglycemia, early morning hypoglycemia, and post-dialysis hypoglycemia would be even more important. Or if the patient is walking into uremic hepatic encephalopathy and the ammonia levels are high, I may have to tweak the type of protein which is required for the patient in the form of a branch chain amino acid. So basically, it's a whole gamut which I need to take care. I don't only need to look at the renal parameters, I need to look at all the biochemical profile in order to design the diet chart, which could be a personalized or a customized diet chart. Obviously, when I talk of 24-hour recall, it could be a patient may just say, I'm taking a cup of tea. But today's fad is he consuming a green tea, or is he consuming a masala tea, or is he consuming a lemon tea? Is he consuming it with honey, with sugar? What is he really consuming? If he says breakfast, if I'm going to say he's consuming chapatis, is it bhakra roti or it is jowar ki roti? Because now millets is totally in. So if he's consuming an idli, is the idli with the coconut chutney or the podi idli, which is commonly consumed in southern India? Or if the patient is consuming a chapati or roti, is he consuming it with chana masala? So I think diet is one thing which is very, very complex, and we have to be a very, very good listener and a very, very good observer, both, and it cannot be done only with the patient. It has to be done with the family members, probably with and without the family members at two different points for us to understand the patient's 24-hour recall. Now, after the recall, obviously the prescription, and it ends with counseling. But I would want to make a very serious and a fair comment by saying that most of our renal failure patients, because of as hemodialysis progresses, their urine output starts coming down and ultimately becomes anuric. Their intake is super compromised. And because of the fluid restriction, they also have constipation, which also could be a reason for hyperkalemia. And this whole vicious cycle leads to poor intake, which can most often be helped with oral nutrition supplements. Obviously, we need to be very, very careful when we are counseling our patients pre-dialysis and once they have walked into dialysis, because the diet for pre-dialysis patients is totally different from those who are on dialysis. And not only that, those who are patients, I would say persons with diabetes, the PWDs, if they are having diabetes, their diet, which was only when they were having diabetes, than when they are with DKD on dialysis, is totally a contrast. So initially, the first counseling is a confused counseling for the patient or the attender. So at least 45 minutes is required for the first counseling. And after that, it does not end. In another 1 week's time, if we are able to pull the patient or the attender back again, I think we'll be able to give quality information to the patient with less confusion. Obviously, all the remaining, the anabolic hormones, steroids, correction of acidosis, anti-inflammatory agents is all part of the nephrologist, which I would not deep dive into. Then what is my plate? My plate is different for somebody who's having diabetes, somebody who's having diabetes with early stages of CKD, and those who have walked into hemodialysis. So it's definitely personalized. It depends on a lot on the serum potassium, phosphorus, also the uric acid levels. Most often we also see hyperuricemia, and the triglycerides are also raised. But as soon as we see the triglycerides are raised, we do not jump into, nutrition intervention by decreasing the fat so much, because we want to push carbohydrate, fat, protein, all in balanced proportions in order to improve the nutritional status of the patient. How do we assess the energy? Obviously, the gold standard may be indirect calorimetry, but it's not practical. Most of our institutions do not have, methods to do indirect calorimetry. So we use predictive equations. And as I mentioned to you, we can do the 3-day food record. The 3-day food record should, eliminate the holidays, should eliminate the festivals, should eliminate the fasting days, though we do not allow our patients to do fasts. Apart from that, they should also eliminate functions. All this is eliminated, and then we do the 24-hour recall of the dialysis and the non-dialysis days. Sometimes we've also noted that due to the intradialytic weight gain, also the intake is compromised. So on those days, if the intradialytic weight gain has been very, very high, then the intake is very compromised. That sort of a 24-hour recall may not give actual information to us. Apart from that, we have the food frequency questionnaire. That is over a period of a month. We put down all the food groups. In the food groups, the individual recipes or the food ingredients, and we determine how often they are consumed. Are they consumed 3 times a day? Like, for example, if they're consuming rice, are they consuming rice in the form of an idli, in the form of a rice rava upma, or rice? If they're consuming, if they're consuming fruits, are they consuming it in the form of a fruit juice, or is it tender coconut water? Another important thing in our recall should be the lot of WhatsApp videos, social media videos going on with a particular green leafy vegetable, mixed in the form of a juice. If you consume it, you need not require dialysis. So many, the social media has ruined the nutritional status as well as the progression of CKD patients. So we have to be very, very careful in determining what sort of kadas and soups and juices they are consuming, which can have an impact not only on the potassium, but also on the fluid and the renal function. So these are the guidelines. I think all of us are quite aware of the guidelines. Basically, the guidelines, I would say guidelines are guidelines. They are not lifelines. So each of our guideline helps to guide us how we need to move forward, but we need not depend on them totally. Our patient is an important Bible or Gita to tell us what is the guideline for that particular patient. Every patient cannot fit into this 25 to 35 kilocalories per kg body weight, or every patient may not be able to fit into the 1.2 grams of protein per kg body weight. Each patient is different. Yes, we do respect and regard the research associated with coming up with such guidelines, but definitely each patient is different. So we may not be able to fit into these calories. Say, for example, if the patient is only consuming 5 kilocalories per kg body weight, if we put the patient to 25 kilocalories, he's going to walk into refeeding syndrome, wherein there could be a raise in the TGL, in the blood glucose levels, and there could be metabolic abnormalities, as well as changes in the magnesium and phosphorus, apart from the potassium. So calorie calculation, cumulative calorie deficit based on his weight loss in the past 3 months, all this will give an idea as to what the target calorie is and what the initial calorie is. For example, as I mentioned to you, if somebody is consuming only 5 kilocalories, I will have to gradually progress this to 25 calories or 35 calories based on the BMI or the weight loss of the patient. But I cannot start with 25 kilocalories. As I mentioned to you, protein also is 1 to 1.2 grams per kg body weight. But if the patient is, say, suppose we have a renal cell carcinoma on dialysis and the patient is awaiting surgery, so the protein requirement may go even more higher. Now, those patients who are hospitalized and they are on conventional intermittent chronic kidney replacement therapy, their protein requirement is higher than 1.2. And those who are critically ill, they may require 1.3 to 1.5. And those who are on prolonged intermittent kidney replacement therapy, they may require even more higher protein, as high as 1.7 grams per kg body weight. Now, when it comes to PD patients, as I mentioned to you, we are aware that they lose from as high as 20 to 30 grams, in 24 hours of PD. So their requirement of protein is as high as 1.2 grams. But we need to remember, with reference to the calories, we need to measure the calories which are obtained when they are doing the PD from the dialysate. So most often we will see that, say, suppose the patient's total target calorie is about 2000 calories, he may be consuming somewhere between 500 to 800 calories from the dialysate. And if he's, on the overweight side, he's at risk of hyperglycemia also. So we need to remember to measure the total calories absorbed, deducted from the target, and provide the remaining calories for the PD patients. So this I've mentioned to you already. Now in PD patients, I'm little very worried with this 2 to 4 grams of sodium per day. Even WHO tells us for a normal individual 5 grams salt per day. And of late, I have been seeing a lot of prescriptions between 5 to 6 grams of salt per day. The reasoning being that the lower the sodium intake, the patient is more malnourished because the patient is not able to consume the meal very comfortably. And if the patient is having associated heart failure, even more difficult when you tell the patient to have a sodium restriction. So this 2 to 4 grams really troubles me with reference to sodium. Yes, if it is salt, it's okay. But if it is sodium, it really worries me. With reference to potassium in hemodialysis, yes, there may be hyperkalemia, sometimes hypokalemia or normal potassium values. But in terms of a PD patient, the patient's requirement is much higher. So here we are not very, very worried about the potassium in PD patient, but still we need to look at the serum potassium values. Now, with reference to phosphorus, for those patients who are not on hemodialysis, who are just still in CKD stage 2 or 3, with there we suggest the Plado diet, which is a plant-based diet, a low-protein diet, and more the plant-based, more the phytate, so the phosphorus is not absorbed as much. But on the other hand, for those patients who are on PD, we need to remember that phosphorus is not easily removed by dialysis, and about 50% of the phosphate which is consumed on regular basis is going to be retained. So wherein the phosphorus restriction is there between 800 to 1000 milligrams. But always remember that when we choose on the processed foods, they contain more of inorganic phosphorus, which is more than 90% bioavailable to the system. Now, there was a mention of the vitamins and minerals on measurement with reference to research, but here we understand that a lot of water-soluble vitamins are lost during dialysis, and most importantly, similar to that, as they are lost in urine, and except for folate, which is very, very highly dialysable. So this is the recommendation with reference to the B vitamins, and this is a summary of the total nutrition prescription which is provided to a patient who's undergoing peritoneal dialysis. Now, I would want to make a mention, this is a very wrong notion which everybody carries, that dates are a super source of iron. They are not a source of iron. It's only the dried dates which are a source of iron, but these dried dates are also a source of potassium. But the quantity of dates which one would consume may not actually have a great influence on the potassium, on the serum potassium values. So basically, I mentioned to you, there is not a single CKD patient, either CKD or CKD on dialysis, who can be managed without oral nutrition supplement. And if the patient required, he needs to be enterally fed. And if required further, it could be either IDPN with reference to hemodialysis patients, and IPA with reference to peritoneal dialysis patients, which I'll be talking a little later. And a word of caution with reference to long chain omega-3 fatty acid, it is not recommended whether it's for mortality, cardiovascular disease, or AV graft and fistula patency. And with reference to micronutrients, I've already mentioned to you the B vitamins with reference to the PD patients. With reference to HD patients, yes, folic acid, if there is a documented deficiency, either folic acid or vitamin B12 deficiency. Or for vitamin C, there is an existing RDA, which is higher for male when compared to the female population. Vitamin D, if there is a documented deficiency. But whereas the fat-soluble other vitamins like vitamin A, E, K, or zinc and selenium, there is not enough data to tell us that they require supplementation. Now, with reference to calcium, phosphorus, and potassium, obviously, we need to remember that calcium could also come from phosphate binders, and phosphorus can come from medications, it can come from diet, it can come from the processed foods. So all these things have to be kept in mind. And there was a very beautiful pyramid, Indianized pyramid, which was shown by Dr. Iyengar. And I think it gives us an insight that the adult pyramid also has to be designed by us who are handling adult patients. Now, with reference to potassium, it's a very, very tricky thing. Something like, for example, if a patient is, now most often, not everybody comes to the consensus that they want to leach the vegetables. But in my experience of past 30 years, I have been working with CKD patients for past 30 years itself. I have been seeing that if there is hyperkalemia, and that hyperkalemia is associated with dietary potassium intake and associated constipation, we need to correct the constipation or improve the constipation. We need to pull out the foods which are the ones which are rich in potassium. And if required, we need to leach the vegetables. Then we see that the hyperkalemia improves. But suppose the patient is consuming absolutely less than 1,000 milligrams of potassium in his diet. He's just consuming half a chapati for breakfast with about a katori of dal, and lunch is just 2 spoons of rice with half a katori of curd, and dinner is just 1 fruit and a cup of milk. Where is the potassium coming from? Major potassium is not coming there. There, I don't need to worry about leaching. So it's all understanding the potassium-rich foods or the phosphorus-rich foods, and then deciding whether the patient requires leaching or no. But most often, we have found that there are so many foods which can be leached. In those patients with hyperkalemia, we do suggest leaching. Now, sodium is a very, very tricky thing. Now, there are so many salts available in the market. We have the recent, the most expensive salt, the Himalayan pink salt, which has about 3 milligrams of potassium per gram of salt present in that packet. So, but how much salt are we prescribing? Between 3 to 5 grams or 2 to 5 grams. So the amount of potassium which is walking from that very, very high potassium salt, is it contributing to the hyperkalemia? I wouldn't say it may contribute to hyperkalemia, but definitely I can say that if I'm going to pull out that puro salt or the Himalayan salt and put the patient on a regular iodized salt, which is not a potassium containing salt, I can allow the patient to have a little more fruit extra, a little more dal extra, or a chapati extra, wherein there can be improved nutrient intake. So these are the various salts available in the market, and the best salt is the table salt, which has the least amount of potassium. But remember, this is all 100 grams. We are not going to consume 100 grams. Our prescription may lie between 3 to 5 grams. So the amount of potassium which is consumed is quite low from when compared to the directly coming from the salt. But yes, for those patients who are hypertensive, non-CKD, we use such salts, potassium salts, for improving blood pressure. Now, ideally, it is a big no for processed foods, but still, when anybody is consuming a processed food, it's our duty to tell the patient to understand that 1 milligram of sodium per kilocalorie consumed means the sodium intake from that particular processed food is way high. Now, these are certain nephrotoxic additives which are available in the processed foods, obviously we do not suggest, but I would want to make definitely a mention that most of the oral nutrition supplements have asulfame potassium as a artificial sweetener, and I'll be talking more about it towards the end of the presentation. But the asulfame potassium is contributing towards the potassium in the oral nutrition supplement, but it is within the calculation. Now, this is to tell us whether the product is sodium free, very low sodium, or reduced sodium, depending on the sodium present in standard serving of a processed food. Now, when it comes to potassium, I would want to definitely make a mention that there are so many foods which are low in potassium, moderate in potassium, and high in potassium. Okay, we have the list which is ready. So 0 to 100, and I'm grateful to Dr. Sarah Jacob ma'am, from whom I learned about, renal nutrition in way back 30 years ago in CMC Vellore, because we had that orange booklet which taught us a lot of potassium, phosphorus, sodium, all of it. But now the times have changed. From nutritive value 1999, we have come to Indian food composition tables 2017. There is a gross change in the micronutrient or the electrolytes like potassium, sodium, phosphorus in the food ingredients which have been presently studied in 2017. So based on that, though we say that 0 to 100 is low, above 100, 100 to 200 is moderate in potassium, and more than 200 is high in potassium. Still, if a particular food is containing, say, about 116 milligrams of potassium, like apple, I would still call it as a low potassium food, because I can consume between 75 to 100 grams of apple and say that it's a renal friendly food. So I most often tell my patients eat PPP: apple, pear, papaya, pineapple. It's an easy way to remember. I'm not very, very happy with the thought that watermelon is actually low in potassium and grapes is low in potassium. I really don't think that these two, because whenever we've seen patients who are dehydrated or there is hypokalemia, when we tell them to take a watermelon or a sweet lime or a lemon, definitely the serum potassium values improve. But the Indian food composition tables do tell us that these are not very, very high with reference to potassium. And the only vegetable which is low in potassium is the tinda. And if you look at the salad, we would suggest only cucumber as a salad. Yes, onion once in a while. And tomato, they contain more than 200 milligrams of potassium. So choose between 50 to 100 grams of tomato per day. Either you use it for a salad or a chutney or in your cooking, however you want to use it. And this is a paper which tells us that, the different methods of leaching are there. One is soaking overnight in warm water. Second one is putting it in boiling water for 4 hours. The third method is pressure cooking it and discarding the water. These could be methods to leach the potassium. The same method could be used to leach away the phosphorus also. But we need to remember that so many patients come to us and ask us, we are losing a lot of nutrition when we are doing the leaching process. But I usually tell my patients is the risk of hyperkalemia and the damage of hyperkalemia is much higher than the losses of B vitamins, which can be replaced with a supplement. So these are the methods of leaching. And it's important to tell you that something as small as rice also is a super source of potassium and phosphorus. And thankfully, we can leach it. So remember to leach the rice. Whether there is hyperkalemia or no, we are always at risk of hyperphosphatemia. So remember that we need to leach the rice. And most often when we tell the patients to leach the vegetables, we should remember to tell them to season the vegetables. If we don't tell them to season the vegetables, they come back telling us that we just boiled the vegetable, threw away the water, and incomplete sort of a leaching was done. Hyperkalemia still persists, and the patient is not ready to eat that boiled vegetable. You need to remember to add another 2 minutes to your counseling and tell the patient to season the vegetable the way they want to, with minimal amount of seasoning, so that there is not enough potassium coming from the seasonings also. And there's a lot of hype about millets. We need to remember millets not only, if the ones which are available in the market are the ones which are the polished millets, so they are not glycemic friendly. Apart from that, millets are a bumper source of phosphorus, potassium, and poor quality protein. So, and we cannot leach the millets except for kodo millet, which is a fairly decent source of potassium. So these are the foods which I would want to bring to your notice. The high ones are the ones which are high in potassium, that they are in red, orange. I'm calling the traffic signal here. If you look at them in the cereals, I would restrict the whole wheat flour to about 50 grams, keeping in mind the potassium and the phosphorus. And I could choose on the rice rava, or the vermicelli made from rice, which are, which could be considered as a moderate source of potassium, and they can be leached also with reference to all the vegetables, except for the tomato. All the vegetables and the green leafy vegetables can be leached. But remember to ask your patient, patients come back to us saying, I'm drinking barley water, I'm drinking plantain stem juice so that it behaves like a diuretic and my kidney may function very, very well. So all these things have to be kept in mind. Now, when it comes to tamarind, look at tamarind. It comes under the fruit variety here. 100 grams of tamarind is going to be a source of potassium, but I'm not going to consume 100 grams of tomato in my rasam or in my gravy or in my preparations. So I need not put it into the high potassium group because the quantity what I'm consuming is very, very small. And if you look at concentrated sweets made from milk products, definitely they are a bumper source of both potassium and phosphorus. When it comes to beef, chicken, goat, they are all sources of potassium, but potassium can be leached from the chicken. When it comes to fish, you can remove the potassium and the phosphorus from the fish, but the fish may become, very, very mushy and soggy. I don't think you may be able to even consume the fish. But when it comes to nuts, it's a big no with reference to those patients who are not on dialysis, but on dialysis. Those, I would say the poor man's almond is the groundnut, which could be leached and provided, because if the patient is a vegetarian and he's from a lower socioeconomic status, he can definitely rely on groundnut. And I do not know if you can still manage to buy paneer, you can leach the paneer of the potassium and the phosphorus and still give quality protein. So when it comes to the foods, remember, say for example, if I'm using mint leaves and coriander leaves, they are a rich source of potassium. But if I'm going to take only 20 grams, which means my potassium intake from the coriander leaves or mint leaves, just a handful of 20 grams, will become much less than 100 milligrams from mint or coriander. Now the patient is edible. So as I mentioned to you, these are all foods which are high in potassium. Not necessarily all these foods have to be restricted. Reason being, you can leach them. Fruits, you can choose on the low potassium fruits. Those which are moderate and high potassium, choose only one piece. Like guava, you can have a small piece of guava. You need not have the whole guava. Leafy vegetables can be leached. Egg yolk needs to be avoided. Roots and tubers can be leached. Pulses can be leached. The whole grams, the chana, rajma, rongi can be leached. The milk products, only the paneer can be leached. So you restrict the milk to 300 ml per day. Nuts can be leached. Choose on the healthier nuts. Nowadays, the patients are consuming a lot of seeds, flaxseed, chia seed, all the possible seeds in order to keep their health status on the very high. But remember, we do not allow them to choose on these seeds because of the potassium and phosphorus, and we will not be able to leach these seeds. Now, when it comes to, those PWDs, the persons with diabetes, whatever is glycemic friendly need not be low in potassium and phosphorus. So keep that in mind when you're choosing on foods. Also in vegetarian population, you can choose on mushrooms. You can leach the mushrooms and provide it to the patient so that will give some amount of quality, not quality protein, some amount of good amount of protein. And also tofu can be leached, which will also be giving you some amount of quality protein, because the only amino acid which is limiting is tryptophan over there. Now, when it comes to phosphorus, yes, the beautiful thing here is this tool which was used by Arpana ma'am is also available for the adult population. But I think as dietitians, we all need to work on the Indian form of this pyramid. A recent thing which I learned from studying off late in 2019 was the role of dietary phosphorus in relation to protein ratio. So there's always ambiguity in understanding when do you call a food which is high in phosphorus. See, when our requirement of phosphorus, dietary phosphorus is about 1000 milligrams per day. And for most often for our patients, we tell them for potassium restriction is 2 grams per day, 1.5 to 2.5 grams per day. Though the RDA is 3.5, but potassium restriction for hyperkalemia is between 1.5 to 2.5 grams per day. So we've classified 100 to 200, 200 and above for potassium. So for phosphorus, when our requirement is only 1000 milligrams, we are bringing down our classification to less than 50, 50 to 100, 100 and above as low, medium, and high in phosphorus. But the other way of, looking at phosphorus-rich foods is when the protein and phosphorus ratio is crossing more than 12 milligrams per gram, you could consider that food as high phosphorus food. For example, if you look at egg white, the protein and phosphorus ratio is 1.4 milligrams of phosphorus per gram of protein from egg white, in comparison to egg yolk, which has 23 milligrams of phosphorus per gram of protein coming from the egg yolk. So this particular food can be considered as a high phosphorus food. So here I mentioned to you already, processed foods, millets are super sources of phosphorus. They cannot be leached. Nuts can be leached. Chicken can be leached. Egg yolk has to be avoided. Pulses can be leached. Milk, paneer can be leached. Tofu can be leached. Green leafy vegetables can be leached. Wheat has to be restricted to 50 grams per day where there is a problem of hyperphosphatemia. Also, you can choose to, boil rice, leach away the rice, add some 50 grams of wheat flour, add some spices, some garam masala, finely chopped onions, green chili, and very little bit of coriander or mint leaves, and make masala rotis for patients to enhance their intake. Now look at this. All these are red. All the spices and condiments are red because they are very high in phosphorus, but the amount we are going to consume in our preparations is between 1 to 2 grams per patient. So we don't have to worry about these spices, except for dhania powder, that is coriander powder, which is a rich source of potassium, which usually in South India, they add to red chili powder for preparation. So we usually tell our patients not to grind red chili powder along with coriander powder. So this is the poultry, which is once again high in phosphorus, which can be leached, not a problem. Avoid ready to cook, ready to eat, and ready to serve because they are all processed, high in phosphorus and potassium. If you look at this slide, such a big information telling us, I want to go salt-free, I want very little mayonnaise, no cheese, no tomatoes, only a piece of lettuce, and tell the cook to towel off all the excess fluid, substitute apple slices for fries, and don't put pickle on the plate, add a glass of crushed ice, please. It's like, the person, the homemaker, the wife, the mother, or the lady of the house, whoever is doing the cooking for a CKD patient or CKD on hemodialysis, it's like actually she requires a word processor to process the whole thing and prepare a menu. But believe me, a dietitian can make life very, very easy by just empowering herself with the knowledge of the electrolytes as well as the protein and the calories of food. So don't keep the plate empty. We do not have a perfect eating plan. No perfect, there is no standard prescription for our renal failure patients. One size does not fit all. If you look at this, the sambar is a bumper source of potassium and phosphorus. So what can we do? Just leach the dal and use the sambar, even if the patient is on dialysis, unless and until there is recurrent hypokalemia and hypophosphatemia, and unless and until there are normal serum potassium and phosphorus values. I usually tell my patients if they're consuming dal 3 times a day, then definitely to leach the dal at least 2 times and have regular dal once a day. And on day of dialysis, prior to dialysis, they can consume an almost near normal diet, whatever they want to consume, on the day of dialysis, before dialysis. So these are all the dals which I mentioned to you, which are regularly consumed by us, and the whole grains which can be leached. So try to fit into their shoes and choose on realistic options so that they provide energy in the form of based on assessment, tailor-made, and practical solutions. Think out of the box. Yes, there is no harm in my patient eating from 50 grams of wheat flour, a puri, and a potato masala, leached potato masala, if there is a potassium raise. He can have a masala dosa, once again a leached potato, if there is a problem with the potassium. The patient can have gajar ka halwa. I can leach the gajar and put very restricted quantity of milk instead of putting khoya, which is used in preparation of gajar ka halwa. Remember, all the milk sweets are a major chunk of potassium and phosphorus, but if a very small quantity is consumed, it's not to worry. So go the extra mile and try to tell them. I remember when I did my internship 30 years ago, sago was considered as a, low in potassium, low in phosphorus, low in this, low in that. But remember, it constipates your patient. So if your patient is constipated, if you're going to choose on sago as a major cereal, it's going to worsen the hyperkalemic status. So empower yourself, understand the potassium values, phosphorus values. And this is a more so, a chart which will provide you as high as 2,200 calories and 55 grams protein. But if you remember, most of the oral nutrition supplements are super sources of fat and sugar. In the oral nutrition supplements, in our diet, we can add whatever we want. We can do a lot of permutations and combinations in order to enhance the calories, enhance the protein, especially we have the freehand with reference to our hemodialysis or PD, and juggle along with the fat and the sugar, bring it down, increase the other foods which can be leached if potassium and phosphorus is a problem. So this is a small exchange list, which is part of my diet metrics book, which provides all details on sodium, potassium, phosphorus, and glycemic friendly foods. I was making a mention of the artificial sweeteners, non-nutritive sweeteners, because a lot of our PWDs, that is persons with diabetes, are CKD on hemodialysis. This is a recent paper wherein they have studied about 1 lakh population for a period of several years from 2009 to 21, and found that whether it's aspartame or sucralose, they should not be consumed, or asulfame potassium, because they are at a risk of coronary heart disease, cerebrovascular disease, or cardiovascular diseases. So as a dietitian, we need to be patient and reply. And this is intraperitoneal amino acids, which you can use in your patients who are PD patients. But there are restrictions over there also, though it provides 22 grams of amino acids, and it can improve the nutrient intake, especially the protein intake. But there is a contraindication wherein you cannot use it in urea levels above 38 millimoles. You cannot use them in metabolic acidosis, IEM patients, or severe hyperkalemia. You cannot use IPA in such patients. When it comes to IDPN, yes, it can provide you from somewhere between 700 to 1000 kilocalories. But if they are allergic to egg, corn, soya, peanut, olive oil, or they are having dyslipidemia in terms of hyperlipidemia, like TGL is raised, or congenital inborn errors of metabolism like phenylketonuria, you cannot use it for these patients. And also not to be used in severely undernourished patients. You can use it in undernourished, but not in severely undernourished patients. So IDPN, but remember IDPN, there is a risk of refeeding syndrome. It's just like TPN. And also the patient can go into metabolic abnormalities because of excessive overload of calories suddenly. And also there could be risk of hypoglycemia by suddenly calling off the TPN when you're doing the dialysis. So strategies for improving care is, it has to be a patient-centered approach, and we cannot do without the help of the nephrologist, the registered dietitian, the physician handling in the dialysis center, the dialysis technicians, the patient groups, family members. Telling them once is definitely not enough. Thank you for your patient listening. Timely nutrition therapy is essential both to prevent and treat malnutrition and improve survival. Keep calm and trust your nutritionist. Thank you for your patient listening.
Thank you, ma'am, for that excellent session. It was very informative. Now, in view of the short time, I would like to go to the question and answer session. So, Dr. Sandeep would like to know, kindly elaborate the process of leaching of vegetables.
There are 3 ways with which we can leach. The first method is you can soak it in warm water overnight and discard the water in the morning, and then do the preparation with whatever you have leached. The second method is you can put it in boiling water for about 4 hours, discard the water, and then the product is leached. The third method is pressure cooking it and discarding the water. The fourth method is the open pan boiling. Open pan boiling is you finely chop whatever vegetable you want and you put it in excessive of water. After you put it in excessive water, you boil it once. That boiling will be between 3 to 7 minutes. Within 7 minutes, you could have the vegetable boiled. After that, you discard the water, again add fresh water, again boil it, discard the water. So this whole process is done 3 times. So only thing, the problem is this cannot be done for fish. The fish will be really mushy. You cannot consume the fish in any form.
Okay. So the next question is from Dr. Manju, who asks, what about fruits for patients with diabetes and CKD5D? Patients who are on dialysis with
So
diabetes.
as I mentioned to you, glycemic friendly fruits as well as potassium friendly fruits are APPP, apple, papaya, pear, pineapple. So for papaya, we may have to restrict it to 75 grams. Yes, you can even take the gooseberry. Gooseberry 100 grams is a source of potassium, but we are going to take only 1 amla, 1 gooseberry, 1 large gooseberry, which is not going to be a source of potassium. So we don't have to worry for that. Even watermelon is glycemic friendly. It has a glycemic index of 72, but glycemic load is only 2 to 3. And our IFCT also tells us that it's not very high in potassium, but I'm a little worried about it. So I would say to consume it only about 50 grams. Guava is glycemic friendly, but it is very rich in potassium. So it needs to be restricted in terms of quantity which you're going to consume.
Okay, ma'am. There are another couple of questions. This could be open to all speakers. The question is from Dr. Prasanna Babu, who asks how to assess healthier weight gain in patients on HD and how to differentiate this from edema.
Yeah, this is a situation where actually bioimpedance vector analysis is going to be useful. So if you have the only thing which is actually preventing us from doing is we need to have some normative data for our population. And many of the newer machines have the tool software for doing the vector analysis. The answer is BIVA for peritoneal dialysis patients. But again, you need to keep in mind that bioimpedance is going to measure the water in the body, not in the third spaces. So you should be careful while interpreting the total body water content, because whatever 2 liter or so, which is there inside the peritoneum, that is not going to be assessed by bioimpedance analysis. But BIVA will tell you whether it is fluid or whether it is muscle or fat the patient is gaining by looking at where actually your vector stands in the ellipse.
Okay. Another question is, what food should be prescribed for sarcopenic patients?
A rehabilitation of sarcopenics is a complex issue. So basically, there is sarcopenia, probably we might have reached a point of no return. So the identification efforts has to start in CKD 2 or 3, whichever is earlier or at the first contact of the patient. And there are so many interventions which can actually reduce the development of sarcopenia. But once sarcopenia develops, that's going to be really in a difficult terrain. You have to, and obviously if there's a nutritional component, you have to address the nutritional component, because especially rural population who eat polished rice, not much of non-vegetarian stuff, predominantly plant-based diet, they will actually be taking only around 0.45. Our own experience catering to rural Tamil Nadu patients. Okay, you might be knowing better than me. Okay, so Ganga in her thesis, probably 0.45 was the protein intake. Okay, which actually means that they are they don't even actually go near 0.6 or 0.8. 0.6 should be perfect if actually you are taking a protein of high biological value. But considering the fact that we Indians take mixed proteins mostly from vegetarian sources, 0.8, at least 0.8 should be given. But what our patients, especially the rural patients, getting is exactly half of what is recommended. So these patients need intensive protein rehabilitation. You have to step up the protein in their diet rather than restricting. And another unwanted side effect when you step up protein is, okay, when you actually go for rehabilitation, you have to even go beyond 0.8. And when they are on dialysis 1.2, you can even go up to 1.4. We are not dealing with a regular dialysis patient. We are dealing with a patient who is actually malnourished and who has not been taking protein. And invariable adverse effect is the phosphorus will go up. But never in a malnourished patient, never restrict protein to keep the phosphorus in the normal range. You prescribe phosphorus binders because malnutrition is going to kill the patient faster rather than hyperphosphatemia and vascular calcifications.
I would like to add another point, a very interesting and informative point, Dr. Priyambada. And congratulations to Dr. Meenakshi for exhaustively covering all the points on nutrition during dialysis. Basically, in most of the sarcopenic patients, as you said, I mean, if we could identify it even before it hits the mark, it would be great. But one thing we see in most of the dialysis patients is there is this concept in most Indian patients that once they are diagnosed of certain disease, they feel that they should not walk around and do their normal chores. So even that minimum kind of persuasion to make them realize to do their normal chores, walk around and lift even minor weights can actually help to turn that whatever protein increase we are trying to give in their diet, help it to turn over to muscle mass. But then I have seen it is a hell of a task to push these kind of elderly patients into, doing some physical activity. I think that is something that has to be tackled by even the nutritionists.
Yes, true. Because see, it's actually very difficult to make a dialysis patient do some exercise. Okay, leave alone exercise, making them walk or making up doing the household chores, as you told, is going to be difficult. So probably a major part in preventing sarcopenia is just to ensure that your muscles are under tension. Do the regular work, do some isometric exercises, and okay, you can actually make them exercise during dialysis. You can actually do some isometric exercise, even the 20 or 30 minutes of dialysis. That also goes a long way in preventing or even improving sarcopenia. So diet is one component. Exercising using the muscle is an equally important component. So you have to combine together to deal with sarcopenia. But still, once it has gone too far, you cannot expect dramatic improvements.
Absolutely.
There is another question from Dr. Sandeep. He asked, what is the dietary advice to avoid a reduced constipation, particularly in dialysis patients, CKD 5D?
Apple is 1, bread is 2, Mary biscuits is 3, and all the vermicelli and maida are things which can constipate further. And the convenient way of, recently we have used it for both our onco and renal failure patients is to take a hot cup of milk with a teaspoon of ghee. Though this is Tata Pati Vaidyam, whatever you may call it, but we have seen wonderful results. And I think it's helpful for those patients where the fluid restriction is there, where intake is compromised, physical activity is very, very poor. So this is really helping us. So within the fluid allowance, within the milk allowance, a hot cup of milk with a teaspoon of ghee really does wonders. And saturated fat can be taken up to 7%, whether you're somebody with PWD or without PWD, it's not a worry. Yeah, apart from that, obviously you can take papaya also. That also helps. And we tell them if potassium is an issue, phosphorus is an issue, leach your green leafy vegetable and consume green leafy vegetable. No harm in that.
Yeah, so this role of constipation in hyperkalemia is often understated. None of the algorithms, if we see, we all deal with medicines, but constipation is when you have advanced kidney disease, your gut compensates and your your stool becomes the only route for excretion of potassium. So for those who are in training, whenever your patient complains of hyperkalemia, I would say the first question you have to ask along with the diet is, are you constipated? And if the patient is constipated, simple thing, sometimes the patient might be able to eat whatever diet the patient is taking, but simply managing the constipation might settle the hyperkalemia. Unfortunately, that does not come in nephrology textbooks. You will learn by experience after some time.
I agree, because we have seen in our own unit when we introduce a good amount of low potassium vegetables, leaching or without leaching, it has improved. It has not contributed to hyperkalemia. It has not caused hyperkalemia. In fact, it has helped in even controlling hyperkalemia by relieving constipation. Gut issues are really one of the things that we have to look into.
In children, what we have seen is oral iron and oral calcium. They can exacerbate constipation. So,
but one more thing I would want to supplement here is, in fact, I had seen in all my years, I had always seen hypocalcemia, but I had seen one patient with hypercalcemia because the patient had fractures and was post-operatively suggested calcium supplementation and then forgotten about it. The patient having very high calcium intake and it led to hypercalcemia. So I think we need to look at all the electrolytes and the minerals, just not looking only at sodium and potassium and phosphorus.
Yeah, that's another thing. So probably we don't really have strong indications to supplement calcium in dialysis patient. You want to bind phosphorus, you use a non-calcium containing binder. And whatever low calcium dialysate we use, let it be 2 millimole and all, that is actually having relatively higher calcium. Whatever 2 millimoles converts to 8 milligram of calcium and 100% is ionized. Whereas in our body, only 50%, that's 4 milligram or 5 milligram is going to remain ionized. So dialysis patients are always at risk of gaining calcium from the dialysate, irrespective of the dialysate calcium you use. The higher the calcium, the greater will be the chance of gaining it. Even if you use 1.25, still actually it might be 5 milligram of close to 5 milligram of elemental calcium. For someone whose ionized calcium is 4, still the patient is going to gain. So probably this practice of prescribing calcium, it should be limited to those who have symptomatic hypocalcemia. Better not to use it as a phosphorus binder because we don't really have any control. Whatever diet we eat, there will be 1 gram of calcium, and whatever additional calcium we supplement, another 500 to 1 gram comes, and we don't really know how much the patient is going to gain through dialysis. So better not to put the patients on dialysis on calcium unless there are indications like tetany or probably a prolonged QT interval or something like that.
I have 2 questions for Bajaj ma'am. Are nutrition really useful, like we use defosteril or astamin? And to avoid hypertension, normally we don't advise to eat during dialysis. So what is your take on that? And during what time of session do you recommend to eat? During initial stage or towards the end of the dialysis? When do you want the patient to take anything to eat?
See, with reference to nephrosterol, we have used a lot of nephrosterol in our AKI patients.
Okay.
A lot of nephrosterol is used in the ICU in AKI patients. And IPA, as I mentioned to you, to be very, very honest, I have no experience with IPA. I do have experience, little bit of experience with IDPN. So I may not, I may be able to only give you all the textbook data with a reference to IPA. I don't have any real-time experience with IPA. And the third thing is, I've had this query always that when the patient, I've asked my nephrologist and my dialysis technicians, which is the ideal time for the patient to eat during dialysis. So they say that do not eat full stomach because they could be at a risk of hypotension. I think the nephrologist should throw some more light on that than a nutritionist.
So basically my take on this is, see, the maximum potassium removal happens in the 1 hour of dialysis. So basically, if there might be people who just cannot actually stop the urge to have an orange juice or so, okay? So see, if the patient is hemodynamically stable, look at the previous history. There has not been any episodes of intradialytic hypertension. I don't really think there is anything limiting the patient from eating during dialysis. But maybe for a patient who has recurrent episodes of intradialytic hypertension, probably we don't really want the blood to be diverted to the gut. So look at the previous history. If everything is fine, let them eat, because at least what from practical experience, many of the patients tend to eat a little bit more when they are in the dialysis unit rather than sitting alone at home. So we have to actually take a middle path. So in theory, yes, it would actually divert all the blood through the splanchnic circulation and cause hypertension. But in practice, many patients actually, they get bored and sometimes they keep on munching, and probably that might be helping in actually, for example, if they want to keep on eating groundnuts, okay, that will go and provide some calories as well as the much needed protein for them. So, and even some amount of protein during dialysis probably is not going to create much of a harm. Maybe decide on a patient-to-patient basis. Someone has a very bad heart, recurring hypertension, probably not, but stable patients, allow them to eat. At least they will act, and encourage them to eat more protein-rich food rather than calories. That's the only thing I have to take.
Sure. Okay.
So, thank you, everyone. Alas, as all good things have to come to an end, so does this program. I would like to end on the quote by Thomas Edison saying that Doctor of Future will no longer treat the human frame with drugs, but rather will cure and prevent the disease with nutrition. I think today's lecture actually proves to us that the future is here and now. So with that, wishing everyone present many thanks for attending this lecture, and the speakers and chairpersons for not only dispelling many myths regarding nutrition for CKD patients, but for giving an informative and educative session. I wish everyone a good night and good wishes to all. And with that, and with the permission of Dr. Priyambada Madam, I would like to close the session.
Yeah, thank you all. Once again, I believe we had a great session. Thank you all, panelists, attendees, everyone, speakers. Thank you so much.
Thank you.
Good night.
Thank you.
Right.